and engage one another at the right place in the right context and the right conversations. And I think for me, that's one of the biggest issues, because at the moment, it kind of feels to me, and I'm going to speak personally on this one, Zoe's going to kick me in the shins, but it's the fact that we can do so much more and we can do it so much faster if we get that engineering right. And the processes and the agility that sit within the voluntary community sector are much quicker to kind of step forward and do things once we have either an understanding of what the issue is, and or we have the support, the opportunity to kind of engage with other partners to co-create those solutions. The irony is that when we start to get into process, that can take us a long time, and probably a bit longer than it would take other partners around the ICP table. So we need a bit of a lead time sometimes, but also on other occasions we can be there, you know, the drop of a hat and be there tomorrow morning or in 40 minutes, you know, to support pieces of work. So I think for me, that engineering of how we work is really important, and I can kind of see that with the other sector partners too, with the changing kind of ebb and flow of cycles of work and operation, and the sort of electoral side of things as well. I think that kind of creates some challenges that I could see for others too, to do the same sort of piece. So that's where I kind of felt we landed. Lots of good stuff, lots of enthusiasm, tons more that we can do, but not wanting to kind of try and get everybody around the table every time to do it. Let's try and find some smarter ways of working now that we know the sorts of things that we could be doing.
Thank you. Leslie.
Yeah, and I was just saying, I mean, I heard the gentleman's comments of that. I mean, I hope that we're getting to a point in due course, you know, maybe after this group's worked well together, we're actually a lot more upstream than rather than just counting beans of how many people we're treating. It's just, you know, none of us want to be there, do we? Actually being in this kind of difficult situation of an increasing capacity to have to generate that work more efficiently. So I think, you know, so a lot of preventative measures are going to be absolutely critical, and we're all in that space. I found this amazingly useful, and I will fill in. I've got a few bits back from BU and AUV, so I'm trying to kind of coordinate the university's kind of response. As we're a healthcare provider ourselves as ACC University College, so we are, you know, working with lots of people around the table already. So I won't focus on that, but I think just seeing what's going on and having that database allows us as education providers actually to sort of go, actually, could we help with that? Our students, you know, could you do some research? Could you do some student input into it? So we can, because we have this constant flow of people who need experience, actually. Again, with the right, I totally hear what you're saying, John, with the right ways of engaging. This is a really great starting point to actually just see what's going on. Yes, actually, that would be a brilliant research project. We can get some more funding for that. How about working with that together? So there's all sorts of, we're about to get another thought in the oral health area to try and see if we can get some funding around some of that development. To really try and support, because what's good for you guys is obviously often really good for our students, and it's definitely good for our communities. So, you know, we want to train more workforce, but again, having other opportunities, not just even to train them, but actually to retain them. So they're in our staff, healthcare staff and health and care staff involved in exciting projects will hopefully retain them in Dorset, and we become that destination we want to be. So I think, you know, there's that sort of sense of constantly thinking about where we want to be, I think, rather than where we are, and where I spend a lot of my time in my head, I suppose.
And I think that's one of the principles that we're trying to bring to this group is, yes, the ICP. Tricia, did you want to come in?
I was just thinking about the role of the committee and of the partnership, and whether we're really clear on, in terms of the ICP strategy, what elements of it the ICP is delivering, and where are the gaps that the ICP needs to step in, and have we got a set of priority areas that we're all agreed is the focus of the work, because we're sort of in danger of kind of boil the ocean rather than being really clear what some of the drivers are that only ICP can influence. You know, the ICB has the 5 pillars in the 5-year forward view, and that concentrates very much on clinical service delivery, and not just in the response end, but also in secondary and primary prevention. So what is it that the ICP is going to bring uniquely to that sort of levelling up conversation? And the things that the ICP, I think, can really grapple with that the ICP can't, are things like housing, which we already know is a priority. Things like how do we move from being a low wage economy, that kind of stuff, that, and the education piece that really then starts to move people from where they are now to being socially mobile and then living in communities where we're starting to really drive down inequality in its broadest sense.
I think you're absolutely right, and I'm hoping that again that is what partners feel that we're here to do. I mean, Andrew's here to talk about obviously the housing side of things. We have colleagues here from local authorities who are talking about that aspect of it. We are hoping to do something more around social mobility. It has been discussed here, but it needs to go to that next step. The low wage economy, I think the sorts of things that Leslie's just talked about are absolutely pivotal to that change. We've got to create an exciting place where not only do students want to train here, but they want to stay here. And then it becomes somewhere where you can actually start to see a change in that. So I think, I mean, correct me if I'm wrong, if anybody doesn't think that that's what we're here to do, I think we're on message. Some of it will necessarily touch with the work of the ICB, because that's what, you know, we have a lot of colleagues around the table who deal in health, and that's the space that we're in. But we, I think, as partners, know that our role is on that wider piece. So if there is overlap, I think it's just because we're in the same space.
I quickly address the potentially. Sorry,
can I just take Matthew first? And then sorry.
Thank you very much. So, and I'm sorry because those of us on screen missed the start of the conversation. So I apologise if I'm covering ground that's already been covered. For anybody who doesn't know me, I'm Matthew Bryant, Chief Exec at Dorset Healthcare in Dorset County. Just coming in on the back of Patricia's point, I think that the whole sort of landscape of integrated care systems is something that's still really new in the NHS and across care more broadly, isn't it? So we're finding our way, and I think that there's probably a development journey for a group like this one, in which we start with thinking about the strategy and sort of convening the conversation, which I think has been done really effectively over the past year. And then in terms of we then need to find our way, as Patricia's has described, in terms of there not being duplication and working out almost what the unique role is. And I just wonder, I don't know if others on this group would welcome this approach or not, but I wonder if at some stage in our conversation together, it might be worth almost trying to project forwards and thinking, okay, if we were sat around this table in 12 months, 2 years time, 3 years time, given our collective goals, what would we like to see that's been achieved, and what is it that this group is going to drive? Because that might then lead us to a focus on a number of tangible things alongside the ongoing broader conversation, which I think is really important.
Thank you, Matthew. I think that is very helpful, and that is where we're trying to get to, is what are those key things. And this is where, for me, getting those proxy measures that help us say housing's going to take a long time to fix. What's going to be the interim measures that are going to say we're making progress on housing? What has changed in the way we're doing it? In the same way with our education on the road. Sorry, yeah, sitting next to me does have its disadvantage because I can't see it.
It really was a similar point to what Patricia was making. So when I read through the appendices before coming, my question was, where is the ICP in this? Because actually, I think a lot of the stuff that people are talking about are things that we would probably be doing anyway. So it's trying to understand, where is the ICP adding that value, and what is the point that Patricia made? What is the specific thing that the ICP can do that other partners working together can't do? And I wonder if we need to come up with some kind of benchmark around that, so that we can actually see the direction of travel. In terms of some of the challenges, there were things in there like, sharing of budgets, etc., which I don't think the ICP has a locus in. And I would actually challenge us to be thinking about outcomes as opposed to systems, processes, where the budget sits, and what are the things that we need to do where actually it's critical for the collection of the partnerships we work in. And then what are those measures that we're going to use to decide whether or not we're being successful. So I don't know if there's a way to kind of look at everything that's in here and pull out what is specific to the ICP or something different. But I couldn't really get a sense around what the ICP's role is, because I think people wanting to be positive, so talking about things that are working. It doesn't necessarily mean that those things wouldn't be happening if the ICP wasn't here.
Yeah, so I've got Sam and then Rob. Sorry.
Oh, no, after you, Sam. No, go on.
Yeah, helpful conversation. I think just a couple of quick points. When I read through the challenge of writing those reports, there's quite a lot of variability in how people are thinking about how they approach them. So there's a question for me about can we learn from that?
Yeah.
Can we be a bit more specific about giving some guidance as to what we would expect? Having been involved in the ICP strategy, I didn't see a lot of mirroring of what we'd said in the strategy. So I would have thought this is an opportunity for an organisation to say our strategy has started to change to reflect these three big themes. So that's one way where I think we could improve. And then I think the hardest bit is this issue of duplication, isn't it? What's the point of the ICP? Even I struggle with this, because if I think of a big metropolitan area, lots of councils, lots of NHS systems working together, the point of the ICP is to provide a bit of a container for trying to work at scale, respecting the sovereignty of each of those little systems. So you can imagine someone like Greater Manchester or London, there's lots of councils and lots of NHS organisations will still want to do their own thing. What are the things at the level above? The bigger integrated care partnership would be responsible for really driving. So I think it's worth a bit more discussion about what that is. And then the final practical point was, going perhaps in terms of reference, under review and monitoring, responsible for producing an annual plan and review. So can we use some of this information to drive that development of a sharper focus of what we stand for, what we think we've achieved? And even if after the first year we say we're still forming, I think that's okay.
Thank you. And I think that's on reflection in the discussion about what we should set for this agenda. That was clear. People were saying we need to report, we need to review, we need to understand what we've done. And if in that we identify, as you said, that we're going on on a tangent, is that the right tangent or should we redirect? I think that's very helpful. But who is going to do that piece of work between here and the next? How do we actually get that piece of work done? Because this is a challenge for us to think about. Can I go to Rob and then?
Thanks very much. Before I give a reflection, I'm urged to apologise for the tightness of the room. I somehow feel responsible for that. It's hard to believe that after reconfiguration, it can be the largest planned care hospital in the UK. You can't quite imagine it being the largest anything. But anyway, I'd just like to get a quick apology to the chair. I think that my reflection is, in a way, this is a good discussion, isn't it? To say we want to see tangible outcomes that complement the work of the ICB in order that there is clarity on what the ICP is about, and let's have some focused priorities. I think all of that makes a great deal of sense. A reflection, though, is that I think there is good working, and that over the last 12 months, the style of partnership working has improved because we're trying to do that, and that chair will have benefits which aren't recorded here. And it's great to see how many things are recorded tonight at BCP. We hope to get Wessex Fields agreed, and actually the spirit of working, Gillian, isn't that we're sort of acting as delegates for our own organisation. We're acting in partnership to try and get the right result that will give key worker housing within a couple of years and a major contribution to the Dorset Medical School, and real partnership benefits. But it's achieved because we're not just representing our own organisation, we're trying to get different outcomes between us in the spirit of partnership. And I think that's as important as anything else. isn't it? Because that will create benefits down the line that are maybe not recorded today, even though it's very good to see things recorded.
Yes, well, thank you, and I think that spirit comes through in the housing roundtable stuff. Not, I know Andrew's here to talk about that later, but one of the questions I was asked by someone who was on the roundtable, well, we're all doing this stuff anyway, why do we need to have this roundtable? Well, actually, what we need the roundtable is because people work in silos. You know, local authority people by necessity have to look at homelessness and needs. Whereas actually, you know, then you've got businesses looking at key worker housing, and you've got builders who are looking at other aspects of it. We can all work together as a partnership approach. We can actually appreciate that everybody's coming at this from a different direction and hopefully make progress together. And it is that spirit of partnership. This isn't one group trying to say, oh, we just need houses for NHS workers. This is bigger than that, and people have accepted that. Andrew.
Might be worth saying.
Paul, sorry.
Okay. I'm just going to respond to that. There you go. Just I was going to say this later, just on that round table point that Cecilia is around the scheme that you just mentioned on. We've got a meeting coming up very soon around just a more scoping conversation with developers, planners, housing people, registered providers, housing associations to see how we can build on that. We've got good work going on. How do we coordinate it? How do we push on, make some strategic alliances? And that's I guess the things around that for later. That's some of the points of doing this through the lens of this group. It's about how we can build on, you know, some initiative. And it seems like the quicker, even though it's takes a long time to build a scheme, obviously, but I think it's a quicker win for this activity already happening that we can build from. And there's a chance for us to really do better at coordinating NHS estates, housing people, planning people to push on. And I think the key, that's sometimes missing link, is like housing associations, the providers have got a lot of enthusiasm for doing more in the space. We've just got to gather ourselves in a way that makes that work. That's just important.
Thank you. I've got Paul and Jim and then Julian.
Thank you, Jack. So when I read that, I was really encouraged. I just want to say that at the beginning, because there is so much things that are going on that are across our organisations that are in the space that might start making the difference around what we understand to be around prevention, health and equality, those sort of things that the wider determinants. And they give me a sense of optimism that, whether it be because we come together as an ICP or whether because we are building better relationships, we've got a better chance of trying to tackle those things that we've known about for a long time and not really made the inroads. So I read that, I was really encouraged by the list of things that are going on there. And I guess you can't, our role isn't necessarily to go into the detail or to hold those. There's a relationship space that we have here, and we can be very much driven by, can we evidence that we're making an impact as an ICP? And some of it will be so soft that it'll be really difficult. But the fact that we are coming together in all of our diversity and we're talking about the challenges that each of us face or collectively face, and talking about some of the opportunities that we've got, that partners who we would automatically think of will then lean in and actually will have a better opportunity to try and work, and then link those back to the three key priority areas that we are particularly for ICP strategies. So I wouldn't get too hung over about being able to draw a straight line from the ICP to delivering outcome, because I think there's going to be so much soft stuff that we achieve by leading this partnership.
Thank you. I agree. I read them and felt very much more optimistic than sometimes I feel that things are happening. And as you say, whether we've actually engineered them or what somebody else has, at least partners are recognising that those things have shifted, and if they're involved in it. I have now Jim, Gillian, Patricia, and then Louise. So Jim, you wanted to come?
Yeah. Mine was just simply quick redress to Leslie's comments about how I started off by saying that we should be driven by performance indicators. Many have well indicated that I was a bean counter. I'm not a bean counter. The reason why I qualify that is because Matthew actually is responsible for his organisation actually saving my life, which is the reason why, while I was working as an IT consultant, I contracted a viral condition that nearly wiped me out effectively. I was in hospital for 17 nights and realised that I need to repay the NHS for the amounts of expense that had been thrown at me. And therefore, I got involved as a patient research ambassador. I'd like to call ourselves champions, hence why I then journeyed into research through Wessex Applied Research Collaboration, and do work now with Bournemouth University, particularly around neurological conditions, because I've got an unfortunate family condition of dementia occurring regularly. So I'm doing work at the moment with a PhD student as a fellowship to use technology to help people in the latter stages of dementia. The point I guess I'm making throughout all of this is that you've got various people, similarly to me, who are retired and professional people who are data protection officers. There's a guy on our DPEG who's a retired professor who used to teach soft systems analysis. All of those, and we've also got somebody who's a governor, and you know who I'm talking about, who's now doing an anchor role, which may well feature in some further contribution later on, which is patient safety partner. And that all of those allow us, the public, to help and shape the delivery and do it as a role that allows us to truly buy into co-production and co-creation. Because we will then help to shape and advise if it's appropriate, if the next sprint that's planned for delivery is going to deliver something that people can associate with. Because at the end of the day, if we provide demonstrable benefits of ICP, then we'll continue to drive more and more people engaging, not just simply the greys who've got their Zimmer frame being re-rubbered outside, but it's the youngsters that we need to go and speak to kids. And tell them the perils of their ways if they continue to follow their friends vaping. I mean, it's so obvious. But I've now done 7 years, Matthew, and I'm sure you'll know this. I've done 7 years while I've participated with DCH. 6 years ago, I did a digital discovery day, and shock or surprise, 4 things that we identified is virtual wars. The other one is prevention of falls. The other one is mental health, and the final one, the thorny one, was how do we address inequality? How do we encourage youngsters to take their kids out and walk in a green space rather than just simply allow them to watch TV and spend money unnecessarily on cigarettes and all the rest of the things that we know is out there? And if we don't do that and don't step out and actually approach the subject, then we're going to lose it. And I think the involvement of the public is the web thread that allows you to go across all of the silos to challenge activity.
I agree with public involvement, and thank you for your time as well and your contribution. I think it's very important that we do involve public in co-creation, and I know there's a lot of people out there who want to get involved. I've got Julian, Patricia, then Louise, David, and then Ian. So can we go, Julian?
Yeah, thanks, Cecilia. Really fruitful discussion, and I think it shows why this was a useful exercise to test us in filling in this form, and then to take a discussion building from it. I mean, how I approached it, it was unashamedly positive and strengths based. Going back to Jenny's point, and I suppose that's where I come from. On system working and partnership working, is start from what's strong. And build from it wherever you can. So that is the approach that I took to it. But I completely agree we should be looking at the gaps and you should be seeking to fill them with value too. There's a lot of strategic alignment in Dorset, and I don't think that we should take that for granted. I don't think that exists everywhere. I think the existence of the ICP strategy, those 3 strands, the fact that we're all able to get in the room and say, yeah, they're all good with that, we're able to take it to the health and wellbeing board and say, yeah, they're all good with that, actually fits with what we're trying to achieve. That is valuable in itself, so let's not take it for granted. In the examples that I put forward, again, unashamedly, some of them were things that started before the ICP was in existence.
And that's because partnership working wasn't invented with the ICP and with the ICX and all the system working, and that's fine. And I don't think that everything we do has to be about initiation. I think a lot of what we achieve as system leaders is about spotting what works really well and amplifying it and giving it more air and giving it more energy and more fuel, which is sometimes about resource and it's sometimes just about paying attention to it. And so deliberately I picked out the early help programme, which we've gone to the ICP recently. I picked out the access to full partnership, which is something that is just so used to go and find new purpose in our communities. And I picked out working with drugs and alcohol because David and I did just a really impactful for me visit recently to some of our services in VCP, and it just struck me that they were some of the most integrated services I've seen, and that caused me to think, why is that, and what is it that's working there for our work with drugs and alcohol as well. So the wider points about the ICP and its relationship with the ICB, I mean, there is a crowded space in Dorset for partnership working, and again, we should see that as an asset and as a strength. You know, there aren't lots of places where no one's looking at the issues and where no one's trying to solve the problems. That's great, but there isn't blank sheet, lots of blank sheet of paper territory to step into. So that question of how are we adding value on things like housing or any of these wider issues, but we should keep doing it. But we shouldn't stop ourselves from actually saying there's something that's good and let's do more of it and claim the credit for that as the ICP actually has.
That's a very positive way of looking at things, and I love the idea. I mean, test and learn for me is one of the best things to do. If something's working, amplify it. It's a really, really good phrase that I've taken from it. I've got Patricia and then Louise.
I'm trying to be positive.
Go for it. But it doesn't.
It's great that we all come together and have a conversation, but this is 3 hours of really expensive time. And I don't think it's good enough for us to just come together once a quarter and rejoice in the partnership and go away and not be clear on what the partnership is actually delivering. I think we agreed our ICP strategy, and we did it by listening to the public and putting in that document what they wanted to see. And we made a commitment to them that something would change. And we've got to honour that, because otherwise they'll never engage with us again in an exercise because they think we're all talk and we're not actually doing anything to improve their working and living lives. And we've got to start to do something tangible that shows benefit to them, that we can do that you said we did. So for me, we've got 3 strategic priorities in the ICP that are about prevention and early help, thriving communities and working better together. And we either need to agree what we're going to do under those 3 priorities that show that we're making the difference. The other option is, for me, is that we have the 5 pillars in the 5-year forward plan, which is the ICB sort of delivery plan of the ICP strategy. And whilst we've set the priorities for this year, those are only the things that health can do from primary prevention to response. What those programmes of work need is the ICP's response to make them complete. So if I think about respiratory as an example, we can do everything we can from the starting blocks of primary prevention to response. What we can't do is fix the fact that lots of people in the secondary prevention space would not deteriorate if they weren't living in full poverty housing. We can't fix that. So I think we do need to agree what's the work programme that sits under the ICP and what difference is it going to make, because otherwise we're just coming in this room and convening and having a chat about partnership, but we can't evidence that we're making a difference, and I think we have to.
I totally agree, and this is a challenge we have, is who actually does that work, who actually coordinates the programs, who is actually responsible for saying, right, this is what we need to do, let's go away and do it. I've seen, obviously, David has put together an idea of what we could do around creative health. David Freeman has talked about what we can do around social mobility, because we've asked for resources to do that, and he put his hand up to do that, because that's how we have to operate. is on volunteers and other resources from partners to do things. And until we actually have either some dedicated resources to make that happen, to coordinate those activities. I mean, Sam's team were on down for doing some of the work around delivering the strategy.
See,
But
I
again,
think we need resources though, Celia, because the only people that can deliver this stuff is us.
I agree.
So I think if we have a working group underneath that then comes back with some proposals, a subset of us around the work programme, we are the only people in our organisations that can deliver this. And I don't think we need resources because it should be aligned to the strategic work we've got to do anyway as a system.
That, again, the resources that I'm talking about are the people to coordinate those getting those meetings together. That's all I'm talking about.
I'm happy to put my hand up to do something with colleagues, but we do need something that defines what the committee's here to do this year, next year, whatever. And it's a work programme with priorities that we're all going to lean into.
Well, I've got a number of people who want to come in here, so I guess who would like to, is it Matthew wants to respond to this? Any first. And then Matthew.
Can I comment on that? I mean, you won't be surprised to hear, I totally agree with what Patricia's saying. And I don't think it is about adding on additional resource. I think it's about thinking about how we work effectively together. So I just wanted to go back to a point that Sam made right at the beginning, which is what we've got here in the terms of reference. We've just looked at the terms of reference today. This is what should be steering us around how we work as an ICP. And it does talk about focus on facilitating agreement between partners on key health and wellbeing issues. That, I would say, is what the ICP should be doing. Identifying key outcomes and ensure the experience of service users and patients remain at the centre. So let's think about how we bring the voice of service users in. And then openly discuss difficult issues. So I think we've set some things for ourselves already within the terms of reference. What we should be checking is how are we going to deliver against those things, not adding on more resource or adding on more work or trying to claim work that isn't ours, but really focus down on the things that we are here to do. You know, I took Paul's point about the value in the ICP being communication and us working together. But actually, if we think that's what we should be doing, then let's change the terms of reference to reflect that. I would say the terms of reference that we've got at the moment is exactly where we should be. What we're struggling with is actually identifying how we're going to do that. So if housing is a big issue and there needs to be some facilitated discussion around how we do that, let's tie that down and get on and do it. So I would say let's not boil the ocean by adding more to it. Let's focus on where we should be. When we come back to do the review again in a year's time, I think Sam's exactly right. Let's be really clear around what our aims are and then ask the questions around whether or not we have delivered against that. But I think there's a danger that we claim everything, we don't really do anything, and then we use the time that we've got together to just talk about how glorious we are without actually achieving what we've been set here to do.
No, I take that absolutely. I mean, but the whole idea of this was to try and unearth what are those key things. And I think we are working on housing. I think the Housing Roundtable is taking the lead on that work. And again, social mobility is another aspect which I believe that David has started that work towards. But I think partners are sensing that they need that culture change, that different way of working, also to make sure that actually we can work together to do it. And I think from what I've read, that is a message that comes through, that people are thinking about other people to help them through doing things and changing the way that they approach things. I've got a lot of people who want to come in. I've got Matthew, Rob, and Sam. Can I take Matthew, Rob, and Sam on this issue and then come back to David and Ian as well? Sorry, Matthew, did you want to come in on this?
Yeah. Thank you. So again, really leading on from what Jenny said, I think I agree, and I think we need to sort of have the discipline to say, if we're sat here in a year's time, what is it that will have progressed as a result of this group, and then to come back and revisit that conversation. But here are three ideas for what they're worth, and they you know are happy for them to be accepted or rejected. But One is I think this group has got the potential to act as one of the things that binds the integrated care system together. So not everything that this group has oversight of needs to be done via the ICP, and I think we can help to almost pull in bits from elsewhere. I'm deliberately not using the phrase hold other bits of the integrated care system to account, but where there's work going on elsewhere, I think that the ICP can ask for that to be reported back here and discussed here. So it doesn't all have to happen in the ICP is one point. The second point is in relation to resource. So when I look around this meeting is an incredibly senior meeting, and therefore I think if we get our discussion around priorities right, the people sat around this table need to make sure that the resource flows from that. And so looking at the senior leaders around, we then need to take the issues back into our organisations and make sure programmes of work are supported. And I think that that's how we work in other forums when we have the work programme of the provider collaborative or other delivery boards as examples. And then the third point I would make is recognising Jenny's plea not to add more work to the work programme here. There are some things that I think possibly the ICP has got a unique opportunity to make a difference on, and I'll give you an example of one of those. So at the moment, the number of people in the working population who aren't working is a very hot topic, and it's really important both from an economic point of view and from a mental and physical health point of view. And I know that there was a discussion on this at the last ICP meeting, but I think perhaps we have a unique opportunity to take a really good look at the work that's going on within health, within social care, within the VCSE, and with some of our contacts into the private sector within Dorset, and put together a work programme that provides a coherent offer and makes a real difference to this issue within Dorset over the next 12 months. And I would say if the ICP doesn't do that, where else is that going to be done in the system? I would advocate that that's a really important thing to do. So that's just an example of something that we might focus on.
Thank you, Matthew. Again, the people are not in work is certainly something obviously that we did discuss last time round, and is a real issue for Dorset in terms of our economy. Economy is not growing. In fact, our economy is in, I think the term I used was flatline. Was the kindest thing that I can say about it at the moment, simply because of that lack of resource available for people to work, having that impact. So yes, it is something that I think fits into that low wage economy element of that Patricia mentioned earlier on. Looking at housing, the economy, the homes in the economy conference was trying to pull those two pieces together. But health and wealth, again, there's a lot of information out there on those two aspects as well.
And sorry, just very briefly, I suppose what I'm advocating is, I think for partners around the table, there are a number of us who are providing services that offer intervention in that space. And I think they are quite fragmented. And I'm therefore advocating that the ICP could be a space to address that fragmentation, and using the principles of sort of co-production with service users and others, actually put forward a new offer in Dorset that is better and more effective and more financially efficient than what we've got in place at the moment.
So with that in mind, and with everything that you said about, again, the people around the table providing the resources, can we ask by the end of this meeting today that people identify whether they want to be involved in that programme, and if they would like to come together, as what resources they would put to that, such a programme. Thank you for that. I've got Rob and then Sam, and then I'll come back to David.
So it's a very good discussion, and it's a sort of typical discussion, isn't it? Partnership groups meet and think about how do we focus And probably less is more. And to capture some of the things that have been said already, there's an awful lot going on in Dorset, and there'll be a ton of stuff happening. We don't have to capture all of that for the ICP. But what we do want to know is for this year, and then the year after, and the year after that, we don't try and do everything at once, but what are the few things that we would like to get some leverage on, because we think that that would help. So I mentioned respiratory illness. I imagine that I'm making this up, that there's probably quite a lot of work with the councils on their own stock and as a regulator of housing to try and do something about damp and mould. I imagine there's a lot of work around pollution and trying to reduce the use of fossil fuels, but also to try and put trees next to motorways and all sorts of other things. That may be something we might want to accelerate, and we make an ICP priority to say, is there more that can be done than we feel they're presently doing? Or we might just leave that alone. And we might say, when we look at nutrition, we think a bit more could be done about healthy eating. Or so I just think we can't do everything at once, is the point I'm trying to make. And it's not a bad thing to say some of these things are in hand, some of these things are not in hand. So for next year, we'll do something about this. And the year after that, we might try something else.
Yeah.
Rob's just shot my fox.
I didn't know fox hunting was bad.
I was just going to ask a question. It was prompted by Patricia's point about respiratory. I don't often see a system view of the whole life pathway around an issue. I wonder if that would be helpful, because respiratory doesn't start with an admission to an acute ward. It starts with air quality. It starts with the hazards, the housing health and safety rating system. Local authorities collect these incidents of damp and mold. We've got good information on smoking. Take a point, Ken, about being a bit more upstream and the challenge of vaping. There's some really good work going on around asthma and trying to get people to switch away from reliever inhalers to corticosteroids. That's already reducing admissions. And then what do we do about COPD, where there are still people with COPD who smoke, and access to pulmonary rehabilitation is still unequal. So having that pathway shown in simple detail allows us to talk about the opportunities. It's Rob's pod. Are we comfortable with where?
When you say we're doing this, and we want the ICP to contribute to it. Well done, Sam.
But it's not a lot of work. So if as an ICP, we can surface some areas where we are interested in this, we can as a partnership start to pull together everything we're doing when we're looking at the whole age, whole life approach to this as a system.
And is that something that you from public health would lead, that type of piece?
We need some help, because we don't.
But leading it in terms of
We
actually,
can give a steer on what we need to do.
yeah,
And I think it speaks to another challenge that I see in our system. Fragments of this work are being done
Yes.
by really, really dedicated groups. How do we get some time together so we can see what the whole of it looks like?
and I think, again, that's part of the partnership working that I see, is how do we stop those little bits, not stop those bits going on, but know that those bits are going on and say, okay, the gaps are here, the gaps are there, and you're not doing it as well as you could be over there.
We're just doing, as part of the priorities that are in the 5-year forward plan. So we picked respiratory, CVD, and the whole frailty. The portfolio office are just doing a map of all the different groups where all different bits of work are going on, so we can pull all those people into just one delivery group. So if you can link in with them, then we can start to get the whole picture, because we have talked about the fact that a lot of the work that's happening now is purely sat in the primary prevention space, and actually we want to get much further upstream. And how do we engage the broader partnership and some of those other things that you're talking about around smoking, healthy lifestyles, type of employment, all that kind of stuff? Because we've also been talking about the fact that we currently have GPs who do the over 40 health checks, and we also about 20% of them are done by World Dorset. What would that look like actually if we broadened the way that we do over 40 health checks, so they're not just concentrating on the things that DH, they're a much broader conversation around, you know, the impact of the employment you've got, the impact of where you live, a whole range of things that then helps people get into a much deeper conversation about things that they can change in their overall lifestyle that might make a difference, or how they can plan for the future for things that they can't change. So things like when you don't take HRT, what are we talking about? What advice are we giving to them about bone health so they don't end up with a fractured hip later on in the life? Although so it's a much broader, deeper conversation than just let's take your blood pressure. Do you know what I mean?
I do know what you mean, and I think this is where Leslie's point about sort of getting the research and the students involved in that type of work as well, because there must be a lot of evidence already that students could use as part of projects in order to be able to inform.
And we've started as part of the people plan, slowly but surely implementing prevention and population health training into education. So we just started with the junior doctors and then we're scaling that up. And now Dawn's looking at how do you do that with the whole range of clinical professionals, so they understand their role is much broader, just a secondary care element that they'll end up doing, the majority of them.
And if I may, that's a really good example of how the partnership would work, because we could be asking who's already doing work on respiratory issues, who's engaged in that work. So if housing are not engaged there, then the ask to Patricia is to get the team to actually expand who they're engaged with. So,
I've got lots of people. Did you want to just make a comment?
Do you mind? I just in terms, it's partly, I'm using support this, but it's about making sure we broaden out, we open our doors as broadly as possible.
Yes.
I'm a housing director for Dorset councillors who don't know me, so damp and mould is probably the #1 issue for a housing provider.
Yeah.
And accountable to the housing regulator and other people beyond the care partnerships wherever they work. So I'm saying this is in support of concept, but we've got to be really smart about making sure we're aligning ourselves across whatever the topic is, because I've got my own drivers around that in terms of, you know, stock condition, property. A lot of those are health driven. The Our Bishop death in Rochdale, we've got that in common. Keeping people healthy and well, and you know, not at risk. Clearly, that's a massive common factor, but it's not the only factor. What I'm trying to make. So I think just about making sure we're smart about how we carve this up. I'm absolutely in support of this. There are things like damp and mould being an ICP priority and a project that I'd be very keen to join in on, but it needs to be carefully choreographed. So
yeah,
you know, key to make.
But that sounds like a key. That sounds like something that, as an approach, that whole pathway. Is that how you described it? Sam, the whole like pathway on those key conditions, and see where partners hang into that, making sure that if there is something that should be being done, they get involved. But Louise and David can definitely want to be in. So that's what Louise. Sorry.
Thanks, Cecilia. The conversation's kind of moved on a bit. I was going to go back to talking about filling the form in, and I found it very challenging. Because we're not clear about what we're working on. So I found it quite hard to fill in, I must say. But I was interested in looking at it, how many times some things were repeated, that people talked about health inequalities a lot, which I thought was really reassuring, and about insight and how we collect insight collectively, really. And that's where I see the difference. Is we're all listening to people are telling all of our organisations things all the time. How can we bring that together to really see the power of it? That's where I think we can make a difference. And then Matt was saying earlier about looking at the future, looking at, you know, so where do we want to be in a couple of years' time, actually, as a partnership. I really like that idea of working to a kind of theory of change, and then, you know, having some outcomes so that we can show the public, look, here's what you said, is what we're working towards, and then be able to show some clear outcomes, I think would make for really good comms. And for me, that's what this is all about. It's about how do people feel part of this? How do they feel that they can influence the future?
It makes an awful lot of sense, absolutely. And again, that is a key part of. I read into a lot of that there is more engagement, there is more connection, but there is obviously feeling.
And some repeated mention of homelessness as well. I thought throughout quite a few of them. And again, I struggled what to put in there, so I'm not quite sure where I was going with it. But when I saw them all together, I think, well, you know, there is some real collective work there. We're looking at people who face the most extreme inequalities. And to my mind, if we get it right for them, get it right for everybody, the way that services are integrated, and look at the person instead of thinking about the service.
And I think that's a good lens from which we'll be looking at these whole life programs, as well as making sure that we're looking at it from the perspective of the individuals affected, not just from the system and what we think we should be doing.
I like the idea of that, and I think if we play to our strengths, you know, there's the VCD and the multi-sector and Health Watch, you know, we can go and collect case studies in a way that perhaps the system can't, because people are probably more willing to be really honest with us. And so if we work to our strengths, we can bring all people together. That's where I see partnership working.
David, thank you for the patience.
Yeah, I'm going to come back to sort of point that was made earlier in the discussion, but about sort of ICP making a difference. And my view, I guess, is that there's sort of going to be organised outcomes where the ICP have a strategy and priorities, and then we'll have working groups, sort of actions that come out of that hopefully results and outcomes that we can measure. So, you know, that was a good piece to work with. But I think again, there'll also be some consequential or opportunistic outcomes from the partnership meeting, from these partnership meetings, the discussions that we have, conversations that we have, the information sharing, and actually, you know, this paper is all about information sharing, so everybody can see what it's doing. And just in relation to that, Rob mentioned earlier about key worker housing, the Royal Hospital on the Wessex side, and you know, BCG Cabinet has recommended that, and hopefully tonight at full council that, you know, that will be ratified and be backed. But
it would, yeah.
it wasn't just you know, it was just going to happen, and it wasn't just always going to happen. There was quite a lot of risk, involved there, and it's not been easy getting through that process. You know, anybody that's followed the process knows that it was one council committee that's recommended we shouldn't be doing that, and there's been quite a bit of political change. There's been legal change and legal advice against it. There's been some officer advice that actually maybe we shouldn't go there. You know, so you know, a few weeks ago there was a lot of risk in it, and actually we had quite a long potential cabinet discussion around it, and there was some advice that actually we shouldn't expend any political capital. We've got this, you know, political level, but there was quite a lot of political risk if we went this route. How much capital have we got? How many discussions can we have with other groups? Can we bring people on board with it? And it was going to go the other way at one point. You know, so we were having that discussion, and I was able to cite the conversation we had at the last ICP meeting about key worker housing and the provision of key worker housing. Say to my colleagues, you know, this is a priority across Dorset. We need to, and I don't think my colleagues needed persuading, but we needed the confidence that we were doing the right thing and it was going to work for partners, that actually we needed to stick our neck out a bit. And luckily, you know, we stuck our neck out at that point, but some of the risks mitigated and went away, and some of the people changed views. It wasn't always going to be that way. And so actually, I'd like to say it's a consequential effect that actually we had that discussion in the last meeting, and you know, that I was able to share that with colleagues, and that contributed to hopefully tonight getting an outcome. So it's sort of I've got everything crossed. So it's sort of not an organised ICP outcome. There's a sort of consequence that conversation, discussion, information sharing that we're having. So
I think that's really good insight, and I think that's often how things happen. It's that strength of knowing that other partners are with you on this, that our values are such, this is the way that we know that we need to go, that we have the evidence and others will support you. that gives you that's
That information shows, so we're all aware of,
Yeah.
we're working on projects about alcohol or whatever it is, and
Yeah.
there'll be discussions and points that come up. Well, actually, we think that, there's opportunistic outcomes that we produce from these meetings and discussions.
I've got, thank you very much, David. That's really, I've got Ian next, then I think Andy on the screen wanted to come in, Zoe, and then if that's all right. Angela. Ian.
Thank you. Jenny, you mentioned the terms of reference of the ICP, and one is ensure that the needs of people, places and communities are widely understood. I respect, Cecilia, I didn't quite get that sense from your reports. Certainly from Health Watch, as Louis says, is a listening organisation, and the ECS Assembly is another listening organisation. But I only found a few examples of listening to people and finding out what matters to them. Some great ones: homeless people, lived experience, and identifying areas for improvement, UHDs, and patient first methodology. Only one mention of holistic support, which is really, really important. And again, that's Patricia's piece about looking at the whole person, not just the health bit or social care bit. So that's what's missing for me. It may be there, but it certainly, to me, wasn't in the narrative. And I would just want to say we can't assume that community conversations, which started off as 100 conversations and became instrumental in designing what the integrated care partnership strategy was about, that piece has been done, and therefore we move on. Or that Health Watch and BCS are the only people who listen. Every organisation must be aware of the needs and the wants of their organisation. And for me, the whole role of the ICP is not just about systems and organisations, it's about people and communities.
Well said. I'm interested to see how we make sure that we put that all of that listening piece into this whole pathway. Like we may design something that says this is what it looks like, but we do need to test that with people to make sure that we are actually addressing the issues that matter to them, but they say, as well as those things that we know that we need to do.
Can you not just ask that when people are presenting and talking at these meetings? Can't just say what is the community perspective?
What is the
how have we gathered that? If we challenge ourselves to do that kind of thing, then it might help us to make sure we are actually speaking to people.
I mean that came out of something that you wrote, but I don't my best to get other people to speak yet. But that certainly definitely came out of that patient first and asking people first. So yeah, so that's a good ask. Andy, did you want to come in? Sorry, I saw your hand went up and then it went down again. So
yeah, it was kind of talking on the back of the sort of respiratory hub conversation, but sort of more widely. I don't think we've actually grasped the nettle in terms of truly taking up the opportunity for collaborative working across the whole of sort of health and social care and looking at our populations on as a whole sort of holistically. And I think that the respiratory hub idea kind of demonstrates that we've got so much opportunity for improving patient health if we have a coordinated approach. And if you have a respiratory hub that accurately diagnoses children with asthma, accurately diagnoses adults with COPD, ensures that they're on the correct treatment, provides them with prevention plans, addresses smoking cessation, addresses the impact on both work and social aspects of the disease and illness, looks at pulmonary rehabilitation, immunisations. There would be so much in terms of saving for the wider system. There, I'm talking about reducing hospital admissions, but also improving health in the workplace, enabling people to go back to work, less sort of long-term burden of ill health. And I think that's a model we should be looking at, not just in terms of respiratory, but cardiovascular prevention as well. We can have cardiovascular prevention hubs where we have that holistic approach for the patient, and that's the direction of travel I'd like to see us going in.
Thank you, Andy. And I think Patricia mentioned respiratory, falls and cardiovascular. So I think those are the areas that seem to be as priorities. I've got Zoe and then Amanda and then John.
Yes, well, I just wanted, obviously there were these different areas that we were talking about, and I think we do need to come to a decision about what I would totally agree with what Patricia said earlier, that we do need to come to an agreement on what we're actually going to look at, and picking up things so like the quick wins, which for the public, which I think we do need to. And I'd just like to go back to the homelessness one for a moment, as another example of a partnership which we started as a group just before COVID, the Homeless Action Collaborative. That has now grown in the last few years into the Homelessness Forum. That has supported getting the funding from Homewoods for ICP, which none of, everybody, I know lots of my colleagues through System Advice, I mean, they're going, how on earth did you get it, in Bournemouth? And I said, well, we didn't have a problem, it's not, and actually we only got it because of all those. The other thing is that that's also given an opportunity. Yes, there's the social housing, there's private landlords. We've now got a programme, Let's Talk Renting. So we're actually getting landlords to understand that they can, they're not discriminative, which they are, a lot of them, to actually who they're going to have in their properties. And I think the other thing that's also helped with that is that the public's perception, and we've done a lot of work within that group, to actually talk to the general public and say, what is your perception across Dorset and ICP homelessness? Oh, it's street homelessness and it's the beggars. No, it's not. And I think it's that underlying with families, generational families going back to live with mum and dad, and even with all their children, and students. I mean, there's a huge problem with social surfing with the universities and that sort of thing, which is all the hidden homelessness. And I think that sort of thing is happening and it's working. That also comes into social housing, and obviously BCHA and the likes are totally at the forefront of this as well. And I think, to be honest, in that space, there is so much going on, and it does link into the respiratory, it links into everybody else. But I just think that element of it, I would say, is well down the road, and don't change it. And then the evidence and everything else that would be required for, say, the respiratory or whatever, there is data, but there's also stories, and there's all the softer outcomes, which again I think is so more important. I know within System Advice, the softer stories about what actually happened, actually people listen to you a damn sight more than saying we've seen this percentage of the population and we've answered that many calls. So I'm just thinking there are sections of this that we could not leave, but let them carry on, but actually go in for data sharing, and actually what else do you need from that group, and concentrate on something that the public will get another feel of, because it's such a big subject, that, and I just think it's too hard, and you don't want to break it down, because what we're all trying as a collaborative to do on that one is make sure that everybody understands where they are across the.
I mean, I've heard from many partners here that we don't, it's not about duplication. We just, that if we know what's going on, if we identify what's going on, it is about finding the gaps between those elements of it, and how we can then work on what's working well, and identify things that are still missing from those. Thank you. Amanda.
Thank you, Jen. You don't want policing to come in at the end and throw it all up in the air and say that's something completely different. It was just a couple of things I was going to mention. One is we talked about the kind of consequential impacts, and somebody else mentioned earlier about the level of senior representation in this room. Yeah. And I think you shouldn't underestimate the message that sends through our organisations. Yeah. So part of the power of this group coming together is providing, yes, the strategic direction and the framework, but also the permission for our teams to work together on problem solving and finding creative solutions to things. And we've seen that in a number of areas over the last year across the different agencies. And that's something maybe we don't always capture, but I think it's really important. The other thing, of course, we're very outward facing and public facing. I've got real concerns around talking about integrated care, the care of my people in my organisation. And I have to say, it's the first time in our wellbeing and our health surveys that we've seen that mental health and anxiety has overtaken physical ill health in our organisation. And it's not yet a conversation we've had, and it might not be this is the right level, but again, it might be an area that we give permission for our teams to look at across our organisations to say, are people joining us well, serving with us well, and then leaving us well? And actually, if we're not doing that, how well are we role modelling to the public if we're not caring for our own staff about how we can then care for our communities?
Thank you for that. And I would say that if Ian Girling were here, one of the things that business is trying to do is exactly look at that, because they are all facing that same issue. It's not just about people being off sick, it's people being anxious and working below par, being within their own workplace, and what can we do about it? I think the business wishes to get on as well. John.
Yeah, it's coming back to your resource question, Cecilia, because for us in the BCS, people do what they do on a very, very short or tight economic basis. I'm not talking about the money economy, I'm also talking about goodwill and you know, personal commitment and so on. What we're talking about in this group quite a lot of time is things to do with kind of oversight, gathering intelligence, and kind of pulling up to a kind of meta level of stuff. That's not usually a place that people volunteer in. That's not usually a place that organisations have the overhead in their very tight funding structure that mission services or grant funded work to be able to provide that. Occasionally it gets popped out as a kind of side effect. You work on a grant project and you produce a wrap-up statement that could be made available in this space. But it's not, generally speaking, business as usual. It's particularly the smaller and the more local and more community driven you become, the less that's likely to happen. And I'm sort of worrying a little bit about how we sell those kinds of things, the value of that, to make that something that we can get involved in, that we can introduce that into the way that the BCS understands its position in this context, because we won't necessarily have at the moment people who will be able to sit in on these various work streams that are being provided, unless we can find the way that adds where that value conversation can really make sense. I don't think it's impossible, but I do think it's a challenge, and I think it comes back to that question of what really is the purpose of this. And I think there was something about this group being a part of that inequalities conversation, having that scrutiny piece, not just reporting that, but also having that kind of, actually, have you really considered whether this is everybody at the table? That's kind of interesting, and bringing forward, you know, health watch and public engagement work, the community conversations and things like that, making sure they're represented and active in there. So there's been a scrutiny there, and that initiation conversation about we're starting a conversation or we're trying to extend the scale of this work is on how do we get people involved. In both of those cases, how, I suppose my question sort of to myself, but to us potentially collectively, how do we provide that as something that we can put or find the resource, the time, the effort, the motivation, the people to actually do that when we have organisations with very disparate capacity to achieve that. And that might also be an issue for teams, so it might be part of, you know, within everybody's organisation, there's some limits around that as well. I'm just struggling to kind of think, well, how do we structure that? How do we sell that? How do we frame that so that we can all genuinely get behind these projects when they emerge? And the three that are coming through from the transformation team around India, respiratory, CBD and falls frailty, I think we have a chance there to really work this through, perhaps. I would suggest there's some that partnership working, that lifespan, that everybody has a touch point and everybody has a part to play. Perhaps we could surface that as an action that could then lead us to build, if not a model, certainly some approaches that we could draw on going forward and see what the pros and cons and the difficulties are within delivering that.
Thank you. I mean, it does sound like if we can get this pathway to the programme started on respiratory, it will start to give us an idea of what that's going to look like, what type of commitment it might need.
And then that might give you a sense of what additional resources might be needed in the voluntary sector versus what we have available to us from the teams that we try to get. That's, yeah, so I won't make the point. I mean, I totally agree with what Patricia said earlier. I think with all of these things, it's still sort of, it's focusing on conditions, you know, so even respiratory, it doesn't feel, you know, I mean, it's absolutely right because that gives the locus, but around that, you say, what else are we adding in? Because that can't simply be the only thing we're looking at in that interaction with that person. And that is a different skill set and it's a different mindset. And it's trying to stream in that space. That gives us an in.
Yeah.
So what we're putting around that, I mean, I saw this, to be honest, as almost like a mild community mapping exercise, community asset mapping exercise, really. I don't know what's going on in my own organisation most of the time, let alone everybody else's. So actually, that's why it was helpful, just kind of, oh my God, that's incredible, the richness, but we can't spend all of that time mapping everything, of course, and lots of things, as you said, will go on anyway. But I was sort of thinking that the sort of the levelness, so we've got kind of cross system, we've got neighbourhoods, we've got, you know, these, there'll be different priorities for different neighbourhoods, I guess, yeah, so across the system. Those things will largely probably be taken care of locally, so I'm all up for big system change. So I spent a lot of time in Singapore and I can sort of see what they've done there in 10 years. It's actually, they've superseded the fact that governments come and go and priorities come and go and funding comes and goes by being laser focused on the bigger picture and the longer term, and digital being absolutely critical in that. So there's great data sharing. And it's just kind of, it's kind of led to me, it's been a lesson in system work. How we keep on, you know, our eyes on the prize, but work together to get there. And they're quite competitive, I mean, between the hubs, actually, they're pretty competitive anyway. But, you know, I've been watching tube stations getting built 10 years out, community hospitals, so they're integrated, you know, intermediate care was being planned 12 years ago. I think it's how do we make ourselves resilient as a system, despite everything that's going to be buffeting us at any point in time for our people. Because then in the end, it's the people servicing the patients that are the, you know, other sort of ones that get affected by all of this short-termism.
Quickly add to that, and that is that Singapore's been quoted. You can quote Denmark. Denmark have got almost 100% electronic health records that are supporting them. And that's the message, I think, is using technology to help this.
Yeah, and you're right. So in Singapore, it's not even just the linked up health records, they're now pushing out AI generated information and advice. So that it's of those engaging with the service are actually, oh, what about this? If you try this, maybe some, you know, dietary advice, because we can see that you're looking at respiratory information. And I just think that's kind of, you know, great. So
I think you've just painted a picture of a perfect world. It's longer term. It's no political intervention into it. You've actually got that bigger picture, and we've got a resilient plan for the, you know, the care of the people with dorsal.
Technologically, we are leading. There are aspects of artificial intelligence that's emerging on the coast that's giving us an awful lot of encouragement. Artificial intelligence and identifying the root cause of what ultimately becomes an initial condition that's added to increase burdensome throughout their life. We can identify them.
I agree. So have we actually got our priorities? Do we feel that we know what those priorities are that we're going to focus on? I mean, housing, I think, remains something that we will need to act on in and of itself. Although it does overlap with respiratory, it will overlap with sports, but it needs that focus of attention, I think, that continues with that. We've got these whole life pathways that we're talking about looking at, and maybe starting with one to build a model that we think that we can work out what the edges look like on that, and that being respiratory. Although CBD is coming up fast on the heels, and it's not just.
Just going to suggest that we could link with the transformation team and work them up for respiratory and CBD.
Okay.
It's the scope of what's being held by the transformation team. I think that will be there. So that's accepted assumption by the
in the spirit of things that are happening that we may not be aware of, I went up to the Digital Health Rewired exhibition, spoke with IBM. They are doing work at DCH in order to support process mapping. They're calling it process mining.
Yes.
That will actually identify the pinch points, the areas where we can improve, but also potentially start extending the pathway so that we can look at primary care, secondary care, and the consequence of not doing that in an MSK environment is a fall and loss of independence, ending up in a social care.
Sounds like you're on the team, so that's good.
Let's just make an observation, and I'm not trying to be unhelpful. Housing sounds like a priority, but it could mean three things.
Yeah.
It could mean housing supply, it could mean housing condition, it could mean homelessness.
It
We
could.
probably just need to be
We haven't had,
clear.
I think we've got the specific section at the end of here today, and I think Andrew's here to help us with what that's going to be and what elements will stay with
At least
this.
three.
At least three.
But you're absolutely right. I mean, and I think it's can go into bigger than that. But so we've got housing, we've got these whole wide pathways, we have social mobility that we have talked about on the agenda. Is if that were what we were working on, is what are we missing? I think what we're missing then is the idea about work. Good work, getting people into work, the sorts of comments that Matthew was making earlier on about that working population, and that's something that I certainly think that could take some. We've got a lot of that data, we've got a lot of that we could actually take the lead on that as a program and engage them with partners to see what more could be done, because there is in business a fear that we are losing a shorter workforce, as we saw last time. We know that we've got more vacancies than most parts of the country. We are in obviously negative unemployment. A lot of that's due to working age people not working. You know, is there something more that employers should be doing to help to get people back to work? Is there something more that we could be doing as a system to help people back into work?
It's about being a one-way economy though as well, isn't it? Because if you're going to work and you're working for minimum wage, you can't feed your family, why would you bother? You sign up to universal credit, get as many benefits as you can, and even for me, the average wage is so low in Dorset that agencies don't even pay. It doesn't need to pay to work for an agency unless you're a nurse or a doctor, because you don't get paid much more than what you get paid in industries. Wages, when I think about wages where we moved from Dorset in Bedford, wages here are really, really poor.
I know, and our biggest employers at the moment are the NHS and the local authorities and education providers, which again, it shows that we are in that downward spiral that I described, because we don't invest in our economy. I mean,
it's a really good point. We were gathering some interviews recently from people experiencing homelessness. One of the guys I've been talking to works full time. He's been street homeless for 3 months. How is that possible? And whenever we tried to get him help, he was told, well, you can't get any help because you work. In fact, he was being told to give up work, and he didn't want to. So
well, I
just
think
highlights the issue.
I think this came out in our Homes in the Economy conference, absolutely. And again, with the fact that the house prices are so high versus the levels of income that we have. Mm. And yes, we may be low wage, we're not exceptionally low wage, but we are low wage. And it's how to address that so that people can afford to live. The living wage being what Joseph Roundtree suggested was 27% of your income. Well, then that basically means that nobody can afford to actually rent nor buy. So it is something we need to do. Matthew.
Thank you. So I think that Rob Whiteman has given us some really wise counsel through this discussion in terms of where we have broad areas, just encouraging us to think about how we break those down. So I'm going to be, I guess the question in my mind, if you take either housing or employment, and I agree that we should be focusing on them, they're such important determinants of health, but just to be, I'm really ambitious and sort of never want to limit ambition, but I think focus is also important to get things done. And I think that it is beyond the remit of this group to fix the housing crisis in Dorset. I appreciate there could be another view, but I think it's perfectly within the remit of this group over the next 12 months to make some form of tangible intervention around key worker housing within Dorset and agree an approach with the two local authorities on that becomes tangible quite quickly. I think it's within the remit of this group to pick up issues of housing for people with mental health conditions and look at those and how we're responding within the integrated care system. Ditto the housing path for people experiencing homelessness, where there's a huge amount of expertise around the table. So I'd just encourage us to break down those broad topic areas and focus in that way. For employment, I think there are significant aspects which are beyond the remit of this group, but within I come back to within Dorset, there are a number of us providing services to get people back into work. So we heard a great board story at the Dorset Healthcare Board, the meeting before last, from the Dorset Work Matters service, which is a partnership with the Dorset Mental Health Forum. And the most effective intervention we heard for a person who was describing their mental health journey was actually some help with interview preparation, which then got them back into employment successfully. But I know we're doing that for a very restricted group of patients. It shows up in pockets within our organisation. I suspect that within the acutes, there's some of that work going on. I'm absolutely certain within the local authorities, it's a really core area of focus. The VCSE have got expertise. So I would advocate kind of narrowing down to a narrower question to say, can we look at an aspect of employment, i.e. perhaps return to work after a period of unemployment? What are we doing in that space? Map it, and can we be more effective together? So that was the only comment I wanted to make.
Thank you, Matthew. We need to wrap this session. Sam, did you want to come in?
Matthew mentioned the metric I was going to pull out, which is about safe, secure, and suitable housing for people in contact with secondary mental health services. It's about 35% under each council. So to see some movement in that would be really good.
I mean, I do absolutely take the point about the need to focus, and I think if, again, we've got Andrew with us for later on to talk about housing, and I think we should see whether we're on track with that in that report. And in terms of the back to work, certainly it is part of what I know is delivered from both local authorities and through the LEP. And it sounds like you've got specific workforces on there, so perhaps that could be our target. We can visit them.
Well, I was just going to suggest that we also speak about Amanda's point about coming to work well.
Yes.
Be that work well, be the work well. I think that's I think
it's
really important. It's a good way to pick up on some of those issues.
Thank you, everyone. I think that's been a really good discussion. I know it's been difficult, but it's been very helpful to get people's perspectives. I think there was a lot of positivity in what was written. I think there has been substantial change, but the need to focus, the need to deliver, I think we get it. It's how we're going to deliver on it now. And I think we will, we will need volunteers. We will need volunteers from organisations to make these things happen. So thank you. I think we should give ourselves a good 10-minute break if that's all right. So by the time everybody actually makes it to that end of the room for a cup of coffee, it's going to take a good 10 minutes. Is that okay for everyone online? So it's We've got two presentations. So we could start with our progress with place and neighbourhood delivery. Dorset Council.
It's John.
John, hello, sorry. Okay.
Hi there, hello. For those who don't know me, I'm the new Exec Director for Adults, Health and Housing, so I've just taken over from Vivian Broadhurst. I think this is just a verbal item, isn't it, on update. So I guess the main point is that a joint paper went to our Health and Wellbeing Board for Dorset Council's footprint. And that was supported. There's a lot of work in preparation for that piece at the Health and Wellbeing Board, but we supported a co-production approach to integrated neighbourhood teams. Paper really took in key learning from the Portland Together approach, and also supported the development of the required place leadership, partnership and governance to take this forward. Some of the key areas of focus will be around avoidance of emissions, but also prevention and intermediate care. And we agreed to use the Better Care Fund as a key tool to channel some of that investment and schemes, not just for older people's schemes, but across working age. So good debate. Some partners are here today. I'm sure they may want to add to what I've said, but I think a good paper and good support from the Health and Wellbeing Board with that providing an oversight for this future development. Any questions, or anyone else wants to contribute?
John, because obviously I wasn't at that meeting because I've been off.
Yeah.
I'm talking about integrated neighbourhood teams as in the work that the Primary Care Association did with us all. Because is that what we're talking about?
We were talking, yeah, the whole encompass of the neighbourhoods work that's also taken place as well. So taking in all partners into that space, Patricia. But I can see Simone has got a hand up, so.
Yeah, thank you, everybody. So I attended the Health and Wellbeing Board, and as a part of the Dorset GP Alliance, we've started having some conversations with the councils, supported by the ICP, especially in the West, Sarah Howard, I think it's fair to say, but overseen by Kate Calvert as well. And I think we've had some really exciting conversations. If I may say, we started off, gosh, probably a year ago, talking about health leading on neighbourhood development, because, that it was sort of how it had come from a health directive through the fuller stocktake. But actually, it feels really exciting that the councils are kind of really wanting to be involved. And we've had some sort of really good conversations underneath the Health and Wellbeing Board about actually, if we're looking at a bottom-up approach. I think we had a presentation some time ago with Sam Crow, and I can't remember the professor's name, who was very much talking about organic growth and bottom-up growth. And I think this is the conversation that came out of the Health and Wellbeing Board, really. Actually, we keep talking about what is a neighbourhood, and a neighbourhood means different things to different people. And actually, when I think about my primary care network, I think I have 3 neighbourhoods within my primary care network. Does that matter? I don't think it does. I think we just need to start those conversations with all of our local communities, taking into account the ICP strategy and the 5-year forward view, and actually just starting to get on and do some stuff organically. And I know that might not fit with that kind of more governance approach that we talked about in the strategic approach originally, but this is a conversation that means that we can start to do something on the ground. And we've got a place meeting tomorrow in the West at the Dorford Centre, which was a clinical from our West clinical group, just to start having those conversations at network level. And then we've invited the council and some of the voluntary sector as well. So I think it's a really exciting moment for me, and just having Jonathan on board has been really good. And Matthew as well. I can see Matthew's face there as well a little. I know he sponsors the neighbourhood work as well, but you know, you've been there from the beginning, but now we've got the councils. It feels like you've got that tripartite approach, which is how I think it should be. But I know that's the West perspective, and there's a very important East as well that are doing a lot of work.
I think there's probably some mileage in the ICP. I did a bit more of a detailed update at the next meeting from Matthew and Forbes on the work that's going on around integrating enabling teams. Because we've had the National Primary Care Association in, working with teams right across the board on developing the principles of what the model might look like. I think there's a good conversation to be had at community level about what our community see as a neighbourhood, not what we see as a neighbourhood. Accepting that there'll be some things that we'll need to do at scale because it makes more sense, but we do need to have that conversation. At the moment, the thinking that came through from the piece of work that Katrina Kirsty led was over 50 neighbourhoods, and that's not sustainable in the long term. But we do need to have an iterative process that gets us to a configuration that everyone's happy with, and then work through what some high level outcomes might be for those teams. We've got 4 launch areas to start off with, but the intention is that we get all the neighbourhood teams working in some format within the first 12 months, and then start to think about refining the metrics that we'd be looking at. And if you look at the NHS Confed report, and particularly that one and the one done by the Midfield Trust, the work that is cited in there, the model that all the teams agreed with the NAPC goes further than those models that were cited by the Confed. But even in those reviews, the expectation or the outcomes that they've seen is a reduction in emergency admissions by a minimum of 15%. So that sort of gets us into the right space that we want to be around, one, differential investment at neighbourhood and place level that matches the need, and 2, that we start to invest more in the hospital model and shrink down to a smaller level what we invest in secondary care, because we're then able to right size the capacity to what is actually needed.
I think we did see that NAPC report at an earlier stage, so I think partners will have seen that, and it's good to hear about some of this work now getting into practice. I'd heard from John and in your report about the Portland work, and again, it's good to hear about that going on the ground. The bottom-up approach is interesting. I'd like to hear a little bit more about how that bottom-up approach was achieved. What do you mean by that bottom-up approach? And certainly one of the questions I think for partners is what more could or should we be doing to support anything?
I think Matthew could probably talk a bit about that approach that's been used in Portland.
Yeah, I can see Matthew, and then back to Simone. Matthew.
Yeah, yeah, and I'm keen. I'm mindful that we haven't heard from the East yet, so we probably need to do that to have a full discussion. But firstly, I'd be really happy to bring something back to the next meeting of this group. That would be good. The way that this is positioned within our system architecture is the integrated neighbourhood team programme board is reporting to the provider collaborative at the moment, and that's sort of pending the development of the place-based architecture. But we can certainly give an update through to this group. And I think in relation to the point just discussed, my own view is that this has got to be a combination of letting 1,000 flowers bloom, so very much bottom up, which is about the climate, the environment that we create for people to just go and do the things that make sense locally, but also combine that with actually a systematic approach to this across the integrated healthcare system. The important thing is the systematic approach should be an enabler. It shouldn't be a blocker. People shouldn't be waiting for that to happen. It's not going to be the cavalry coming over the hill that provides all the solutions. So the integrated neighbourhood teamwork is though about that systematic approach. We've had the first meeting of the delivery board. Many partners here are represented at that. And then coming back to the next meeting will be the rollout plan for the early adopter sites over the next 12 months. and it would be good to share that here at the next meeting of the ICP.
Thank you. That sounds like a good idea. Simone?
And I don't think I can add much to that really. I think for me, bottom up is just about those conversations at community level, using information, using data, and actually then just starting to have conversations about how you can do things differently, local projects, etc. So it's very bottom up, but it does need to be enabled by some form of strategic framework, etc. So that we're not, as Matthew says, we're not all off going off randomly doing different things. There needs to be process around it. But I think there are some good examples. Again, if I may say, as a sort of proactive PCN, I still feel that networks, neighbourhoods that want to do things should do things, even if they're not an early adopter, because actually, why stifle transformation and innovation if you've got people out there that want to do things differently? And some of that comes down to local leadership and communities as well.
Thank you. Yes. Can I go to our team from ICP rather than and then?
Yeah, I'll just give a quick update because the Chair of the Health and Wellbeing Board has seen update. We had a meeting and workshop back in December, as people will know, and that was sort of discussing our health and wellbeing strategy. And then in February we had a meeting, quite a few of you would have been there, and it was really about the next steps following that workshop and moving from strategy to action. And Sam had a really good report to sort of get us on the right page and go forward. I'll just sort of summarise quickly where that went. So we we basically considered the draft findings of the joint strategic needs assessment, the council's corporate strategy, the aims of the integrated care system strategy, and we sort of agreed we needed to focus on action, especially getting clarity on priority work programs for emerging space partnership. Basically, recognise that the Health and Wellbeing Board has a leadership role in supporting a strong place-based partnership, and we need to offer a lead governance role to the partnership to enable the delivery of the championing early health prevention. There was quite a bit of discussion around it, but really the recommendations are that the board members support a proposed approach to the wellbeing strategy, which is just a light touch refresh with a clear focus on priorities for place-based partnership work plan, and to discuss and agree the next steps in developing the board's lead governance role in relation to the place-based partnership. So it's difficult with the health and wellbeing board, we're still sort of getting a bit used to it, but it's not that we can sort of say, right, we're going to do this, we can do this, we can do this. It's, I think we have a role in sort of holding it to account and making sure it progresses and actually has a strategy that actually says these are the priorities. We need to make sure that they're progressing in the right way, and we need to speak to them to us to account on that. So, so yeah, I think a really good workshop. I think it was good. Good meeting in February. We were due to meet again yesterday, but that meeting was cancelled due to election issues. So yeah, we're meeting again in July. Yeah, and I suppose just around this discussion about integrated neighbourhood teams and the place-based partnership work, I suppose I've been particularly persuaded, and Julian and I discussed this after we had a visit to our drug and alcohol services last week, and it's really need to bring focus about how they sort of break down areas of work across different, whether it is health or social care or the workers across all the different areas. Julian said something to me the other day, and that was which struck me, which was about because they've got a very focused common purpose in terms of that individual with an alcohol addiction or pregnancy issues. That that's their focus, and they'll work with whoever partners or break down whatever barriers or make different decisions, go where they need to go to sort of to address that. And that's something for me that for the integrated neighbourhood teams, making sure that there's a real clear focus about this is what we're going to deliver for this place, so that people will take those steps to sort of call who they need to call and then just break down those barriers.
It sounds like you've got a lot of that process that you're thinking about starting to nail that down. And do you have an area that you're thinking of, and the protection, I mean, Portland has been key to sort of the work that's been done so far in establishing that? Is there somewhere that is that not the approach?
Yeah, I mean, in terms of integrated neighbourhood teams specifically, we are further behind Dorset, and Dorset have been running a programme to support for quite some time now, and we haven't been. Boscombe is the kind of top of everyone's list for us to get started. I think we do need to move into action quite quickly on that now. What I would say about the wider discussions on integrated neighbourhood teams, it has really felt like it is starting to come together over just the last couple of months. I think the delivery board that Matthew and Forbes have convened, then some more working level discussions that others have been having outside. It's helped us reignite a relationship with the GP Alliance on the GCP footprint that I think is not as strong as it can be. I would say, and we've got some more discussions about that coming up tomorrow. On the governance point, Matthew, I just wanted to sort of check, because I took away a different point in terms of what we did read on the governance at the delivery board. I thought we agreed the option where it would report jointly into the provider collaborative and the health and wellbeing boards. I thought that was the decision that we took because of that need to reflect all the different sort of partner interests in it, rather than saying you're waiting for a place-based partnership to sort of be created. That was one of the options on the table, but I didn't think it was the agreed option.
Shall I come in there? Gillian, thank you for your correction. I do apologise. As you might detect from my voice, I'm slightly befuddled by cold. And of course, you are absolutely correct. And I know that I'm coming to the next meeting of your Health and Wellbeing Board and looking forward to it. And I've had a similar conversation with John. Thank you for the correction.
So I've got Debbie and Sam who want to come in. Was there someone else that I missed? John. Oh, and Siobhan, you were first. So Siobhan, Debbie.
So just the integrated care team working. It's incredibly complex. And I suppose the bit I want to sort of firstly say is really welcome is that we're trying to develop a framework, obviously, across Dorset, but we're also enabling people to get on and make some change, which I think is really, really helpful. From a sort of acute hospital perspective, obviously for us here, as we move to the emergency site and the planned care site, over the next 18 months, it's actually imperative that we have the pace around some of the integrated team working, because it's going to be just so important to support the sort of changes in the acute pathways that we're making. So we're really welcoming the work that's going on. The provider collaborative allows us really to sort of keep the pace across all the providers and actually look at how we can lean in as much as possible to support the sort of changes. And then the Health and Wellbeing Board focus, that we really welcome as well. It's really good because we're in this together.
Definitely in it together. Debbie.
Yeah, thank you. I think that sort of people are saying what I'm wanting to say, but I just support what Patricia said. I really think we could do with a paper coming back that sort of really sets out the work that's being done. I think that we've been talking about this, and obviously there is a lot of work from what people are saying is actually happening, but in sort of support of the other discussions we've had today as well, I guess we need to deliver something in 12 months. So I think it will be really helpful to know what are we actually aiming to deliver in this 12 months, and then kind of like I hear what you're saying, Simone, but I think we've chosen our 4 areas. I think we need to really sort of like get some pace behind it now. And so maybe that just is happening, but if it's not all pulled together, and I certainly haven't seen anything sort of paper-wise to see. It sounds like a good paper went to Health and Wellbeing Board, but I haven't seen that. So it would just be really good to capture all of the work that's being done and then actually put some real focus and effort and get some momentum around the priority areas that we've chosen, really, for me.
And who would write that paper? Who would be the best person to create that?
Matthew and David.
Matthew and David. Okay.
Because Forbes and I are the sponsors of this work,
Yeah.
and I guess the reporting point I was making is that within the ICB structure, so this is reporting to the provider collaborative, which reports to SEG. So that's where the reporting paper will come. I'm very happy to do a report here, and of course we are, as Gillian has said, reporting to the health and wellbeing boards as well.
That sounds like a lot of reporting. I've got a couple of. Sorry.
No, that's simply why I wanted to be clear on the lines of communication, because otherwise there is a risk of duplication and not having that clarity.
So I've got Matthew and then Matthew, Sam.
Yeah, so I just wanted to pick up on David's point. I think it's a really important insight. He talks about driven alcohol services as a model for integration. And one of the things that's very, very evident in those services is they are way, way ahead of involving people with lived experience. So people will go into recovery and quite often end up working in the service and know exactly how to build trust because they've been through it and they're trusted. And it's worth bearing that in mind, because we've had some conversations about where's all this insight, where's all this conversation with communities going. If you're really going to look at people holistically, then invite people in communities with experience to be part of being around thinking about the next tranche of solutions. So thank you for mentioning that, because it hadn't occurred to me at all, but I think you're absolutely right. It's a really, really good example. And I was going to say, in terms of the Portland project, Gillian, that you're right. That hasn't happened in BCP Council, but we have had a Poverty Truth Commission sitting for nearly 2 years now. And I think building on the insight and the learning from that commission will be really important in the next iteration of what those neighbourhood teams will be dealing with and how to.
Thank you. Got Patricia and then John and then Leslie.
Yeah, so I was just going to say that in support of Debbie's point that yeah, we don't want to stop forward thinking PCNs, we want to be creative, but that work does have to be done in the context of one, the fact that we have to use our resources efficiently, which means we will have to do some things at scale because we won't be able to deliver what we need to within a confined budget. And two, we are starting to work through as an ICB with our commissioning arm what our commissioning intentions will be. We're clear what they will be this year because we know that the evidence says the integrated neighbourhood teams won't be targeted with delivery very much in the first year because it'll be about the formation of the team and the operational policy and all that kind of stuff. But we will start to think about what the commissioning intentions are in the longer term from 25, 26 onwards. And within that document, we will be clear what the outcomes are that will be required for our population. And so it's important that any of that work that starts in earnest outside the framing of what Matthew was leading on in terms of the launch pads and then the iterated start of the other teams gets done in that context.
So what you're saying is that are you suggesting that you don't get PCNs to try something new? Or
I'm not saying that. What I'm saying is if they want to try something new, Matthew needs to be part of that conversation.
Okay.
Because it needs to be part of that structured programme of development. But also they need to recognise that one, there may be some things that the programme decides to do at scale because it's more efficient, and two, what the expectation around delivery will be laid out in the ICB's commission intentions going forward.
That's clear. I just wanted to make sure that we weren't saying no, but if you want to do something, this is how you approach it. Okay, that makes sense. John.
I think the questions sit on all three of those words: integrated neighbourhood teams. We don't yet have understanding of what the integration needs to include. We don't know what the neighbourhood footprint needs to be, and the team operation needs to really, we do need to kind of recognise the fact we're grappling three things at once, somewhat similar to the conversation earlier this morning here. I think what's really intriguing me is the fact of the kind of natural neighbourhoods that are being uncovered. Simone rightly pointed out the three in here, PCN. we're seeing this, Weymouth and Bourton are bracketed together. They're not just, they're not one neighbourhood. They are 5 or 6 neighbourhoods actually, when you factor in all the different parts of Weymouth. So we've got some really interesting challenges there. And again, this part of saying, with the drug and alcohol service, for instance, there's some really good examples within the family hub development, the access wellbeing hubs, the reframing of some of the networks that are being delivered outside of health that are pulling, from their point of view, putting together kind of integrated working patterns and so on, which I think, we've got to keep our eye on everything, which is really tricky. But I think it's our only chance of success to not kind of either create undue additional burden, but also we can then start work really at pace, because we've got some really good exemplars that we can build from. And Portland's mentioned a lot, but there are so many others out there as well that we could look to in terms of that combined service delivery across the sectors.
Thank you. Can I, Leslie, and then Rob will have the last word on this.
Yeah, it was just to, obviously on the Boscombe side, I mean, you guys will both be very aware of the planning that's gone through for the Boscombe Towns Fund developments. And I'm sitting on the board, I'm sort of constantly trying to engineer health into that discussion. But again, it comes back to, there's lots of different elements here. And actually it's taking that step back and making sure if we're doing that, actually we can do that at the same time. And actually, otherwise we are duplicating effort. And each time it feels like it's different conversations that could keep happening. There's a medical centre that's planned into that. So actually, where that fits into the name, I don't know. Obviously. So I think there's lots of things upstream, and I think that's why this actually, and this is a really good example of why this partnership's really useful, because actually these hopefully, which I spent 5 years of jobs trying to work out, the different systems and the interplay. Actually, hopefully these things won't fall through the gap, and we can step forward together and make sure that we're, actually, if we're doing alcohol work, we're actually, those people have all health needs, and they'll have this and they'll have that. And how we bring all of that together.
Thank you, Rob.
I just want to make a brief point about the money. Probably like many of us in the room, I've seen integrated work get going and succeed, and then 5 years later it stopped. And so there probably is a challenge to us to think about, it's expedient to get these things off the ground by agreeing some short-term things that don't scare the horses. But they need commitment for the longer term, and they need commitment for the longer than our own budgets may be set. Yes. And so in a way, as a partnership, we need to make sure that we bear some of the risk here to make sure that these things have got legs and get the chance to prove a way of working. And that's not to say that everything is then held in aspect forever. Of course, things change. But I'm sure, like many of us, I've just seen too many things peter out, which is such a shame. And often they've won awards and they've been fantastic. But for us to make sure we give this thing legs, in spite of all the financial difficulties, I think is a good thing if we can do it.
I think that resilience point is absolutely key.
I was just going to say I think exactly the point that Leslie's trying to make. The reference to Singapore. That despite financial constraints, politics and stuff, they've managed to deliver. And maybe that's how this partnership works. Keeps its eye on that longer 10-year agenda and keeps us all towards them.
Thank you, Jonathan. Thank you, David, Gillian. That's been really useful to have the update and that discussion. Thank you, Matthew, Simone, and others who've been involved in it. I think it's clearly a key part of the work that we're doing here. I think we're getting a good steer on what the partnership roles are on that. We do have now a presentation from Claire Gailey, who's the Chief Executive of Lewis Nunny, who wants to just give us an example of a new model, an anticipatory care model that has come out from some of this work in. And Claire has actually put together, you gave us a presentation. Do you want to take us through that?
Yeah, sure. Thank you.
And you can do that probably in about 10 minutes. It would be really helpful. Thanks.
Absolutely. Well, first of all, thank you very much for asking me to come today to talk to you. It's a real pleasure and a real honour, actually, to be in the room with you. First of all, a little bit about Lewis Nunny Hospice Care and the landscape in Dorset. It would be fair to say that Lewis Nunny Hospice Care has been going for about 32 years, providing end-of-life care and support for people with life-limiting illness and end of life. We're not the only hospice in Dorset by any means. there are unusually 4 hospices in Dorset. When I first came to Dorset, that was quite a surprise to me. 2 independents and 2 NHS hospices in the hospitals at Christchurch and in Forest Home in Poole. And we all do different things, but clinically work together actually very well. And I think that there's more scope for doing that into the future and more joint working. But if I could just have the first slide in terms of the landscape in Dorset. For those of you who may not know, and I do appreciate that there will be a lot of people in the room who will know this, but in terms of end-of-life care across the UK and in Dorset, around 1% of the UK population will be in the last year of life. And about 25% of that 1% will at any time end up in hospital. Slightly less than 50% of all of those people dying in England will receive palliative care and support. However, up to 90% of all people dying in England may well have palliative care needs. Interestingly, under 6% of people will need a hospice bed. So my question when I first came to Dorset 5 years ago, having found this out and talked to what was in the CCG, was, well, what happens to the other 94%? And that is about them dying in the place that they call home, at home, or in hospital. The number of patients in the UK in receipt of palliative care services is projected to rise significantly. And of course, the CQC State of Care report talks about a system being gridlock, the patients being stuck, issues around hospital capacity and social care capacity, emergency departments waiting for hospital beds and ambulances unable to transfer into hospitals. So in terms of what we thought that we'd like to test and pilot, having spoken to patients, carers, doctors, nurses, GP practices and consultants, I just wanted to share with you a pilot that we've been running for just over a year now. We are planning to continue to run this financial year, but will not be able to afford to run after the end of this financial year if commissioning is taken up for it. So talking to one of the consultants at UHD, an example of one end-of-life patient who at the very end of life, in the last 12 months of life, had 11 admissions into hospital, saw 9 different consultants, 87 days in hospital spent those 12 months, 111 blood tests, 40 x-rays, 4 CT scans and 31 microbiology tests. And at the end of his life, after he died, his carer and loved ones said about the system, everyone wants to do the best. Everyone did the best they could, but there was no oversight of what was really happening. No one really seemed to take a step back and see the bigger picture and see what was really going on. They all did their bit. And it could have been saved so many admissions into hospital, and the system could have saved so much time and money too. So in terms of end of life and admissions, I thought it would be interesting for you to see this graph. This is emergency admissions and the last 12 months of life. So you can see that of the people who died, over 7,000 people who died in this period, more than 8,500 emergency admissions into hospital in the last year of life. More than 43,000 inpatient bed days in the last 3 months of life. And it was believed, and I believe we've proven, that much of this activity is unnecessary and could be modified. So in terms of the case for change, we were looking in, I'm quite a visual person, so onto the diagram, at the situation as it is now. So at the point of a palliative diagnosis, a patient is talking back to their, told that they have a palliative diagnosis by their consultant, often then to refer back to the GP. And quite often, in terms of the life pathway, not that much can happen during that time until the very end stages of life, when often there's quite an amount of crisis. A Friday afternoon, 4 o'clock, patient or carer will make that call to the GP, maybe get referred to 111, an ambulance gets called, the patient goes into hospital through A&E and sits in hospital. It's very difficult in terms of the system at the moment to get that patient back out into the community. Often it's increased workload and it causes an awful lot of crisis. So what we wanted to see was, whether if we put some resource in here at that point, that palliative diagnosis, whether we could anticipate care at end of life and ease the pressure at the end of life and ease the pressure on the GPs and ease the pressure on the hospitals. So we undertook a pilot, and based on the pilot that we did, by putting in support and care at the point of diagnosis, we were able to support patients at that time of diagnosis, fill a clear gap between diagnosis and the need for end-stage specialist end-of-life care. We could see that we had to manage and coordinate at the point of deterioration, often handing over to the specialist hospices or the specialists at that very end point of life, but preventing inappropriate hospital admissions, avoiding hospital admissions, reducing crisis, supporting GPs and district nurses and other providers, collaborating and working in the partnerships with other services, absolutely working with other services, providing the care closer to home, and delivering a number of the strategic aims that you have in terms of well-being, prevention, early help, better working together, improving social isolation, and supporting mental health. And I've just put a note there. This was a pilot, not. I mean, Lewis Manning Hospital does an awful lot of things, but this is just a pilot that I wanted to talk to you about today. So in terms of the data, this is some data from the last 12 months. We weren't on System 1 for the whole 12 months, and we didn't have a full team operating in the 12 months that we recorded some of this data. But from the 1st of April this year, we do. But just as an example, over a 12-month period, we were able to record with the limited resource that we had, a number, 127 GP avoidances, which Shaw Medical told us they would cost out about £80, and 55 hospital admissions were avoided, which the then CCG at the time told us were costed at around about £3,500 when coming in through an ambulance with an overnight stay. And then, of course, you've got the overnight stays that could potentially be there for the patient once they've gone into hospital. And we've costed those out without any additional tests or costs associated, saving £364,000. And that's a really small number in the areas of all the huge budgets that I know that you'll all be working with. That said, it was a small pilot in a small area. I can tell you that from April the 1st this year until yesterday's date, now that we have scaled this slightly more, working in Poole and Purbeck and having put a little bit more resource into it, in April alone, using those sorts of calculations, we've managed to avoid 21 hospital stays, 63 GP appointments, saving the NHS £140,000 just in the first 2.5-3 weeks of April. My question really is, working with other hospices and other healthcare providers, what if this was scaled across Dorset? How much would it save? So in summary, the benefits that we could see from this pilot was absolutely that early involvement at the point of a palliative diagnosis enabled better relationships and dialogue and planning with patients and families. The service became proactive as opposed to reactive. It improved system working and gave much better working together across end-of-life providers. GP avoidances were proved, cost savings were made, freeing up GP time. Hospital avoidances were proved, cost savings were made, improving waiting times. Patients were able to have their preferred place of death. Prevention and early help, the anticipation was, well, it was anticipatory rather than reactive. And it certainly addressed inequalities in terms of well-being and prevention, which should be there for our entire lives. People were supported through the right care, in the right place at the right time. So as I said, it was a relatively small pilot, but if scaled, it could save millions of pounds. It could be rolled out across the Lewis Manning Hospice patch, which is East Dorset and Purbeck, or across the whole of Dorset, working in collaboration with others, and provide significant savings to the system. but also, and importantly, being a much better way of working for the patient, patient's family, and delivering the ICP strategy. It made a measurable difference. And I would ask the ICP and the ICB to see hospices and charities actually as investment centres as opposed to cost centres. As I said, we will need to stop this service at the end of this financial year if we're unable to get funding, and make it more sustainable. But I thought I'd just say some testimonials from the practice nurse that we worked with Shaw Medical and some of the PCNs, PCN Shaw Medical and PCNs over in Purbeck, who said, I cannot describe how wonderful it is to work with you, being Lewis Manning. Without Lewis Manning, our patients would not have the support they needed. He shared the story of a patient who'd been admitted to hospital twice in 2 months because their carer could not cope. That is not unusual. And without Lewis Manning at home, he would have been admitted again. Shaw Medical themselves said this service has freed up GP time significantly and reduced the pressure on our stretched palliative care service. The figures shown has also had a big impact on hospital admissions. Patients and carers have found the service so helpful and feedback's been amazing. And most importantly for me, I think, was from a patient who said the staff have been so kind and thought, oh, she's great. She was very stressed. She was struggling. She thought she needed to call an ambulance. But Lewis Manning came in and she was able to stay at home. Thank you so much for your time.
Thank you, Claire. And I think just to say to partners, Claire is absolutely aware that we are not the commissioning body. That's not why she's here today. But this was a really good example when I heard it of that whole life approach, or that whole pathway approach that I thought. And what it was data driven, had evidence related to it, co-designed with patients, and was looking at our prevention agenda in a way. I just thought it was a really useful example for us just to listen to. So I hope you will feel that too. So Jenny and now for Andy. I think Andy, do you want to come in? Andy Herbert online.
Yeah, thank you. That was a really good presentation and kind of highlights one of the joys to me of being a general practitioner. It's interesting that you say only a very small majority of patients die in hospice, and certainly my experience over 24 years of working in the community is the vast majority of my palliative patients die at home, and that's primarily because I've got a fantastic district nursing team and have the capacity within the practice to provide proactive care. That capacity obviously is rapidly deteriorating at the moment, but I would like to think that we still offer that proactive care. The support from our specialist palliative care teams is invaluable, but I think we also need sort of a collective approach from the wider system. So I'll give you the example of a lady of mine who was 78 who died last week. I'd known her for 24 years. She was admitted to hospital as an emergency with chest pain a couple of months ago, found to have a very large tumour in her chest. She was already very frail, having had numerous strokes, and was essentially housebound. She was discharged from hospital with a plan to readmit her for bronchoscopy and biopsy of the tumour and planning of treatment. And when she was conveyed back into hospital for the bronchoscopy, she said, well, I don't want the bronchoscopy or biopsy. And the person looking at her said, well, you're too frail to have it anyway. And then she was discharged home. And that just kind of emphasizes some of the inefficiency in the team, because if you'd have asked her at the time of diagnosis, she'd have been very clear that she didn't want any treatment, and she clearly wasn't fit enough for any further investigations. But also while she was at home, I'd written up an escalation plan, put in place just in case medicines, even though that she didn't have any requirements for them. And it was 2 months after I'd done that initial visit and written up all the just in case medicines that she died. But literally 3 days before she died, I had a message from one of the community nursing team who'd been out to see her to assess her pressure areas, asking me to refer her for a diabetic foot ulcer. And that came through to me as a task. And I communicated back to say that the patient was in the last days of life, and I felt it was very inappropriate to refer her. And the community staff came back and said, "Thank you very much. Yes, I totally agree." But clearly they were following a protocol and didn't feel in a position to make what was the right choice for the patient. So what I'm trying to say here is that proactive care needs to occur from the very beginning of the patient journey, and that's in hospital, and that will prevent readmissions. We need our community teams to have permission to do the right thing and not have to follow protocols. We have to listen to the patient, but also to look after these patients properly in the community. We need that wraparound care, and quite often it's that late evening, nighttime sitter that is the most valuable carer that we can have for the patient and the relatives. The relatives need the sleep and the rest, and it's that late night admission that is the commonest time where I see these palliative patients going into hospital, and we rely very much on the Macmillan service to provide those sitters. But as I say, it's one of the most joyous parts of being a GP, and I would hate to lose the ability to look after patients like this at home. And I can't emphasise enough how brilliant Forrest Holman and Lewis Manning are.
Thank you. I've got Jenny and Patricia who want to come in.
So firstly, just to thank Claire for that presentation. It was really informative actually, but it really does kind of lift the soul as well. And there were 3 points I wanted to, well, a couple of questions and a point to make. So one of the bits of data that was missing for me from the data that you put up on the earlier slide was how many people die in hospitals. Because I suspect if you ask most people, they do not want to die in hospital. They're quite happy possibly to die in hospice, but most people I suspect want to die at home. And that data was missing. So that might be an area where we want to focus, and I think the work that you're doing is helping to do that. The second thing that wasn't on the slides, when you put up the summary and you talked about all of the outcomes, one of the things that wasn't mentioned was the impact for family members, because I can imagine that service is absolutely critical just for their own well-being, but also knowing that you are doing something to support your family member towards the end of their life that isn't that, you know, that loop around the hospital over and over again. So and there'll be ways to capture that. You know, you had some of the commentary at the end, didn't you? So there'll be ways to kind of capture some of that as part of it. My other 2 points, one was around the cost for you to do this. I don't know what that is, but I expect we know because we provide some of that commissioning, but it'd be interesting to understand. I'm not suggesting you need to do that here today, but I'm sure if we did a return on investment, we could see that is actually valuable service to have. The last point really is a point for all of us in Dorset, because I do think that death is a cultural thing. Other societies, cultures approach it very differently. But we tend to see it as quite taboo here in this country. And I was having a discussion with somebody recently whose mother died, and his perspective was that, yeah, probably because of the First World War, Second World War, when we lost so many people, we kind of exported thinking about death. So we just don't approach it the same way. So, I come from a Caribbean background. I think the way that we approach death is very different, very similar to Irish culture, but we just don't do those things here. And I wonder if, particularly given that we have the oldest population in the country, I wonder if one of the things we should be doing in Dorset is trying to change that culture. So that it's a natural thing. You know, I say to my kids, the one thing you are guaranteed when you are born into this world is that you're going to die. They hate me saying that, but it's a reality. You are going to die. So let's just try to think about it differently and think about how we can help people and their families and their friends in their last stages of life.
Thank you. Absolutely. I'm from an Irish background, so there you go.
So just picking up that last point, I think that that's really important in the context in which we're having this conversation, because this is not the only issue that arises because people in the UK do not talk about death. we have an increase in legal thing around power of attorney and non-massive power of attorney, because people, when they're not, even at the point they're diagnosed with something like dementia or a life-limiting condition, don't have those conversations with family about what their choices are and what might happen when they're not able to make decisions for themselves. So this is really powerful. Thank you, Claire. I think there are some things that we need to concentrate on in terms of how we might change the culture within our hospital sector that helps make something like this successful. Because having spent years as a provider CEO, we train clinicians all the time how to break bad news, and yet they're still really bad at it. They avoid the conversation. They avoid the conversation about de-escalation. They might de-escalate someone because they know they're going to die, but then still treat them because they feel guilty. And this is all why we end up with costs in the system that are completely avoidable, because we don't want to have those really difficult conversations with individuals and families. We have been doing some work on the new end of life pathway for quite a while, and I don't know where we are with that conversation, so I need to go back and check. What we have been talking about last year was we have a system now that is virtual, where our care homes can speak to a clinician to do a virtual assessment and then avoid an admission. And we have been talking about broadening that out to a 24-hour model that also includes end of life, because the area that we purchased that system from in Airedale reduced their avoidable hospital admissions for palliative care to virtually nothing, because what they found was families just wanted somebody to speak to check this, that and the other, and not put someone in an ambulance. So I think we're looking at a whole range of options that I think we need to think through. The thing left in my mind is, I know we say that the majority of people want to die at home, and they do, but some people do want to die in hospital. And I think we've had such a strong debate about dying at home in this country that we've sort of unintentionally demonised the desire to die in hospital. And for some people, that's what they want. And that is okay, as long as that process is managed in the way that they want it to, and it's respectful. I have no idea why we're still having the volume of avoidable admissions, because all of our providers, as part of the national spec, should have a 24/7 oncology on call line, and the whole point of that 24-hour line is to prevent people from coming into hospital if they don't need to, because the oncologist has a conversation about what should happen next. So I think we need to check as well what is actually happening in our system. The final thought in my head is that I think sometimes we make quite simplistic, and I don't mean this to be offensive, simplistic judgments about where we think costs can actually come out of the health baseline. And the reality is that if we save the time of GPs, the backlog is so massive that all that space for someone else. Unless we are reducing our bed complement in providers by a minimum of a 6-bedded bay, there is no closure of beds because of the staffing model that's required. So I think this needs a bit more of a sensitive analysis around what it can actually deliver, and whether the reality is that those cost savings would actually come out of the system to be transferred into a different offer. Because if they won't, we need to think through how we're going to fund that, because we'll be doing the right thing for patients, but we'll be adding cost into our system that we can't afford.
That last bit of the conversation was my life for about 25 years, in terms of people telling me exactly that. You're telling me about cost savings, but they're not really, because they can't really make those savings. Yeah. So we need a new way of looking at this, and a whole new way of identifying how we need to fund and resource the sorts of services. And I think this one, I think is an advanced version of what we're talking about trying to do for respiratory and CBD or others. It's actually looking at the holistic. You've picked up a whole other load of things that need to go into that to actually make it work. I've got Leslie and Matthew, and I'm really running tight on time. So can we just
really briefly? I mean, I'm not going to be a Singapore board here, but when I was out there last time, they were talking a huge campaign about leaving well.
Yes. Yeah,
I just think in terms of a cultural shift, that's the discussion that we all need to have. It doesn't matter what condition we've got, but thanks to Ben, that's really, I know you're an amazing service, but there is just there was just an awkwardness about the whole thing, and actually that's everybody's business, carers, the person
Yeah.
involved, and just talking it through. We just don't have that. It's not an active.
I agree, and that culture change piece that Jen's talked about is how do we work that into that, so it's okay to
I
talk
think
about
that language, leaving well, I think is actually really positive.
Maybe you should tell them for your children that they're going to leave at some point in time. But
No, it's true. I mean, you know, we have things like 9-day celebrations and
oh God,
you just don't have a funeral, you have a celebration. It's nice, as we all know it's going to happen. It's important.
If I just,
Completely different.
I agree with everything that's been said, and my dear old 94-year-old mum died before Christmas with never having a day in hospital, and she'd been out on the bus the day she died, and she was determined that if anything ever happened to her, she'd just go. And I was sort of pleased for her to see it happen. The point I'm getting to is, if we see life expectancy fall in Dorset because people aren't treated to have another couple of months that they don't get any value from and are incredibly expensive, are we in a position to celebrate that? And I just think we've got to be realistic that there is this sort of Titanic of regulation and expectation and performance metrics that we keep everybody living for as long as possible. And dealing with that is big.
I agree, and I think this is where, again, at the beginning, I was talking about those metrics that we need to be able to understand, because actually, if we do this and do it well, actually, we could be shortening life by a couple of months. If there are other things that we do, you know, they may have those impacts, and we have to be able to explain them and understand them. So yes. Matthew, can you come in quickly?
Yeah. So thanks, Claire, for this work, which I think is great. I think the conversation about attitudes to death, etc., really is a really important one, and part of that is about where we are in terms of anticipatory care planning. In terms of Rob's point, you know, that Chris Whitty is keen to open up a debate about kind of healthy years of life expectancy. That's really important. I suspect that this is an example of something where the investment needed is quite small to keep it going, and the potential reward is quite high. And I think somehow in our system we need to find a way of removing finance being a barrier and making it be an enabler in terms of being able to evaluate things like the example we've seen today. And the final point I would make is I suspect that physical health has got something to learn from mental health, which frequently commissions services from third sector partners to do things around admission avoidance and pathway support. And again, I think this is a really good example for us as a system of something we should engage in and try and use this as something which could set a pattern for other things in the future.
Thank you, Matthew, and thank you, Claire. I think what you brought to us is a great example. As I say, we are not the commissioning body, but you've heard the support that you have from partners around the table. And I think if we can work with you to build more into those programs, it can only get better. And work out, you know, the nitty-gritty details that you're able to be addressing. Thank you. Thank you. Now we've got a number of things that we want to get some updates on in what is 15 minutes. So I do apologise. We've got progress updates on smoking, hypertension, and then the housing roundtable. You've given us a good papers, and we've talked about it. That would be a good chat.
We'll plan through the slides.
Okay. Yeah.
Save time.
Please, please.
So just on smoking, I guess some of the things I wanted to touch on. This is about getting into the habit, I guess, coming back to the ICP. So if you remember in January, had a bit of an ambition. We're going to go smoke-free, hopefully 3 years earlier. And that means prevalence falling to 5%. So that's basically finding an extra 35,000 people who are prepared to make the leap and to quit. So I was just going to share a couple of quick points. I talked about the Swap to Stop programme, which was this government initiative to provide us with vape starter kits. I'd like to publicly thank the team that got that up in time for National No Smoking Day. There are still places in the southwest that haven't launched their offer. Already 4,500 people have signed up. But the most striking thing is that more than half of the 4,500 people are from the two most deprived deciles in our population. There are people we would never normally come into contact with through ordinary channels like GP, pharmacy, live well Dorset. So fantastic effort there. There's data on all of the different channels and all of the different ways that we're reaching people, starting to develop those offers. I'm really pleased that when we re-tendered our community health improvement services, we saw an increase in community providers that now offering smoking cessation. So that's gone up from 61 to 102. Big increase there in GP practices providing that service and also pharmacies. So that was really encouraging, got a good spread across the county. Treating tobacco dependency, some data there that shows you how the programme in hospitals, really, really important channel because the numbers are huge. So if we can get the screening right of all inpatient admissions, everyone going through maternity, you're talking about literally thousands of people a year. Just a couple of challenges with that. What seems to have happened is that I think in the Bournemouth site, there hasn't been a team for a while, Siobhan. I've raised it with Richard. Don't know why. The money's there, but something's happening about the posts and the sustainability, but that was different on the Hill site. So Poole is very, very healthy. Bournemouth, not so much. I've got some issues with providing data from Dorset County Hospital. Matthew's still on the call. If we could look into that, understand how we can get that data, that would be really, really helpful. And probably the last thing I was going to say was I talked about the new money that's coming because of the tobacco bill that's passed. We're going to see about 750,000 coming into the local system to support smoking cessation. That's across both councils. The point I was just going to make is there's some big numbers associated with that money. So at the moment, we probably support probably 1,000 people a year formally through our contracted and commissioned services. Probably a little bit more that we don't know about through treating tobacco dependency. But with this new grant funding, we're expected to build that figure to around about 5,000 a year. That's a big step up. We're hoping that the swap to stock effort will work positively with other services to bring those numbers up. It's just an indication of the scale of the challenge. So that was it on smoking. Hope that's helpful.
Quick question.
Yeah.
Is there a link between smoking and medical deprivation?
Yes. Hugely. So that's why reaching the kind of most deprived 2 deciles is so important. Just to give you an idea of that, in the most deprived areas of Dorset and BCP Council, prevalence is about 30%, and the rest of Dorset is about 9%. So it's a big difference.
See, I think there's something about behavioural insights there, because when you live in an area where you are deprived and really struggling to keep your head above water financially, you have very little control over your life. The 2 things you do have control over are do you smoke and do you drink. And sometimes people smoke in those areas because it's the one thing that they can control. And if they can't afford to have a social life, it's seen as a treat. And we've got to get underneath that rather than just assuming that if we sort of have the normal public health messages, people will stop smoking because they won't.
So,
Thank you.
crack on.
Yes, please.
I am going to share my screen a little bit for my hypertension presentation, not because I want to stun you with a whole load of slides, but I just want to show 1 or 2. That's okay. A caveat with this presentation is that I'm not the system lead for hypertension, but I was run at short notice to say, we'll put something together. So this is a slightly different take on lots and lots of work that I think contributes to how we should be working as an ICP. So that's the challenge. 80% to be identified, 80% to be controlled. That's the national target. I won't go through some of the wonderful sharing of my being boards about the current situation. But I do want to show this slide because I think this is really important. This is a sort of whole system approach. Right at the start of raising awareness of the importance of blood pressure, it's not a medical thing. This is a conversation with people. Quite often what people will say is when they first find out in the GP surgery that they've got high blood pressure, and the conversation turns to diuretics or drugs, that's an uncomfortable moment for lots of people who will say, I feel well, I don't think I have any symptoms, why you want them to put me on drugs? So there is something about how we can be very, very embedded in the community to say, do you know your blood pressure? It's important. And the gold standard here is Canada, who've been working on this for a long, long time. Their programme included a lot of support for community champions and having community conversations about blood pressure. There's no reason why those machines shouldn't be in businesses, leisure centres, libraries, barber shops.
Yeah.
The next level is get tested and find support if you do have high blood pressure. And there's lots of different ways of doing that. So it's the primary care is important. Some people want to say, can I lose weight? Can I change my diet? Can I stop alcohol? Can I get a bit fitter? And actually that will also bring your blood pressure down. Do you need someone checking on that? Because if it's not coming down, you may well have some drugs. The third bit is just about primary care management. And I think our biggest challenge is how we think differently about the numbers. Because as Andy will know, 140,000 people on GP registers needing regular review puts a serious logistical challenge into primary care capacity. My question is, do we actually need to review everyone? Ken's point about digital, if you've got people who are engaged, who are linking with patient information about blood pressure, why do we call them in for review? If they're controlled, can we do that remotely or digitally in another way? The people we really need to see are the people who have high blood pressure, who then haven't been back or aren't controlled, or we don't know anything about it. And then because of time, I was just going to share what I think some really impressive work actually that comms and engagement and Kirsty have been involved with, which is this Southwest campaign around raising awareness of the importance of knowing your numbers. So a massive campaign there, not just here, but right the way across the Southwest. What we do know is that in the last quarter, we've seen 3,000 more new diagnoses showing up in the DICE. So something's having an impact. And that's not just the campaign, it also relates to the work by GP and pharmacies to reach out and prompt people to try to have an up-to-date blood pressure reading. So I think the message is it is starting to have an impact. This is going to be a long-term game. There's space in this programme for lots and lots of people to work, and we just need to keep plugging away, really. Over 40 health checks or NHS health checks were mentioned by Patricia earlier. We've done 10,000 in the past year, which is a big step up from COVID. 3,800 of those people had high blood pressure as a result of that check. So they're positives.
Can I stop you there? I think we get the picture. I think you created the picture, but we are talking about this as being one of our focus areas. And I think what you just described is some early wins that seem to be taking some traction.
Forgive me, quick correction. So for his notes, it's James. I was christened James, and most people know me as Jim, not Ken. I think you're referring to me as Ken.
I thought you Ken.
Yeah, yeah. So only for his notes.
I don't know.
I'm not a Barbie. Although the beard might was.
Just thinking of the Barbie film.
He's just said the same. Is it because of the beard? I like to shake the beard off.
Barbie.
I think it's the peak in the presentation.
You know, there is something very.
So I was saying I'm just Ken. I've got 1 minute. I don't realise. Just a suggestion, Cecilia, because the housing roundtable we've referenced for today's meeting. I think this was always going to be a verbal update. It feels to me like a commitment.
Yes.
Every spot that feels like a substantive item and perhaps next meeting. Because there is progress, just one thing I did want to squeeze in there is progress, decent progress around the housing roundtable, which has been set in many ways as a subset of this group.
Yes.
To grapple with exactly these issues. It started off as a discussion around key worker housing, which is important, and we've got meetings coming up with development people from NHS, housing associations, Kelly and myself from BCP and Dulcie County, and planners. So I think there is activity around those kind of sites discussion. The thing I wanted to land there is partly with Matthew on the call. We're very mindful around the potential scope for housing work, around the mental health work, hospital discharge, preventing hospital admission, damp and mold, respiratory disease, all the things we've talked about. They've all got a housing component, haven't they? So I'm going to suggest, Matt Prosser chairs the housing roundtable. We're going to suggest that we, Kelly and I are going to have this conversation as well. It's about how we discuss the scope and segmentation in some ways of how we get that reported back here, because it's all important. It's all part of our respective BCP and Dorset Council housing strategies. We need to be covering off these items, but we need to segment and manage that response well. And I want to do it in a way that fits with how you see things at the ICP. To your point, I know we were at the time. There is good activity around sites and the development piece. And Vanita, Cecilia's colleague from the LEP, Kelly and myself, we look at a piece of work around business data analysis of what, sizing the problem, what's the affordability and employment challenge around the key worker question, as well as sites and development, and broaden out those other sort of rich data we hold within our respective organisations. So we start drilling down into what, sizing the problem, and help us to do what I started off saying, to break down the topic in manageable chunks. I was used for conversation earlier. I think it is recognising that housing is important, but my standard. A lot of my time is spent going into rooms like this where housing big issue. Oh yes, let's define it. Yes. In what way? What can we do? How can we get some practical operational outcomes? So if that makes sense, we could go away, Kelly and I particularly, but also the various NHS folk as well, pull together more substantive items for next time. I think I've had some good steers. Sorry.
Can I just raise one quick point, which is actually really important to the work we're doing at the minute around the right place and reducing costs, in that a number of years ago, when the government changed the Care Act and wanted people with learning disabilities not to be in residential accommodation but to be out in the community, right thing to do, we now don't have enough suitable accommodation, and as a consequence, we and probably local authorities are paying tens of £1,000s a week on care packages for individuals because the accommodation that they're in is no longer suitable for their needs, and so their behaviours have started to change. And so we're providing them with suboptimal support because they're in the wrong place, and that's leading to behaviours that cannot be managed by their existing care package. So we signed one up last week as an example, £10,000 a week. That can't carry on, so we need to work through what the response to that is within the accommodation settings that we've got. Because for me, the cost is an issue. What's more important is we've got people in facilities that are not suitable for their needs.
Well, I think the speed, I think that's probably what I'm trying to say about segmenting that piece of work, is around what we're doing about particular cohorts of people with learning disability. You could transpose that to physical disability as well, about having people in a friendly house, having to have support brought in. So we'll take that as a strand.
But I think so in this context, we have Matt leading that work with yourself and Kelly, and certainly I know Vanita's involved in that. It sounds like we need to make sure that we're getting data from the NHS as well as to what
we have someone in that.
You do, yeah, you already are on that housing table. So that's that piece of work.
Yeah, I suppose that, the thing I'm looking for a steer, I think I'm getting the steer anyway, is whether we look at potentially broadening out the scope of that housing roundtable to start of the discussion around key workers only. It feels like there's appetite for.
I think we probably need to prioritise it, don't we, and where we think the biggest effort needs to go further.
Well, I think if we can, between meetings, we can certainly share papers, get some feedback, make sure that we're on track, make sure the partners agree with it. But it sounds like I think it is key workers and people with additional care needs.
And if you don't mind to say as well, we've at all different stages as local authorities, but we've just completed a housing strategy, and the points that made it before about homelessness. Yes. And housing need and housing register, we're sort of maybe giving you some information about what that looks like, and talking to Kelly about it. Yeah. Some of the solutions are just need some information sharing about what is already happening.
And the way that access to housing lists is managed, because there's some farming things where you can only be on one list at a time.
I mean,
Yes.
without prolonging it, so
Yeah.
like, of course, all the time, aren't we? It maybe there'd be benefit in a bit of teaching about housing for anyone in the partnership who wants to have that.
Yeah.
Because there are, as Andrew says, it's small business and local authorities. There's a legal framework around it, which is sometimes helpful and sometimes really constraining. And that's something that we work with as well. So that's really might be helpful. The one area I would really encourage us not to get into more as an ICP is the homelessness space, because there is, as we heard earlier, it's a huge amount going on. That's not, and I suspect everyone's involved in it as well. I would say if people want to get involved in that homelessness piece, get involved with the partnerships that are already working and driving, rather than us setting up something separate.
Yeah, I think it's all about alignment, making sure we're not reinventing, bottling the action. So to get that aligned.
Because we have everyone up to the principles, including the principles.
So it's been solved.
It is. We've got to end it. We've got to end it together.
Okay. So thank you very much indeed, and I'm sorry to squeeze you for time, but I think you also discussed about housing earlier.
Yeah,
and
that's central.
I think this is one aspect of the work. We know where that's going, who's responsible for it, and what we're going to achieve. We can get a paper for the next meeting that shows what progress has been made, what's the objectives.
And attempt to break it down.
Yes.
Exactly. Yeah.
Break it down to those. I can see Matthew wants to come in.
I'm sorry because I know you're trying to wrap the meeting up, but just as a very quick comment, I really welcome that. Thank you very much. And I think that we do have an issue, a challenge in the system about housing needs for people who have been within secondary care mental health services. And just to illustrate that very briefly, today we've got 22 people whose discharge is delayed, and the majority of those are for complex housing needs. So those people will be coming to harm because they're in the wrong place. But just to show how this involves all partners, in University Hospitals Dorset today, we've got 4 people who are in hospital waiting for admission to a specialist mental health setting. And the impact of those people and the costs associated with that care in UHD is really, really significant, and I know is of high concern. And then out of Dorset completely in other parts of the country, we've got 6 individuals who are having their care far away from home at significant cost to our system, and again, detriment to the individuals and families and care networks. So it's just an illustration about how this issue cuts across the whole of our integrated care system.
Thank you, Matthew. Absolutely. Andrew, and then Louise.
No, fine.
Okay, Louise.
I was just going to say that while we were talking about death earlier and people's kind of thoughts about it, it's Dying Awareness Week in a couple of weeks' time. So an opportunity for us all to kind of share on socials and websites, some of the things that are shared in that campaign that's about talking about death and having good conversations about it. Just timely with us talking about it.
So again, I thank you for everyone's contributions today. For the steer that we do need to focus. I think everyone has said that we need to focus. I think that we've got to a point where we're talking about housing with the need to focus within housing. We're talking about employment and the need to focus on specific areas there, come back with the programme there. And then the 3 areas that we talked about in terms of respiratory, fourth and CBD. Now, I'm certain that the LAP can take the lead on the employment bit and try and pull together a partnership group there. We've already got the round table on housing. I think we need to get the leads identified for those 3 work areas, which I'm sure you already know, Sam, so we can make sure that partners are engaged with those activities. And then the last piece was obviously, I was, as we all were, taken very much with what Claire presented about anticipatory care, end of life, and how we take that piece forward and what more needs to be done there, because clearly what they've got is a really good example and a piece of the journey, but there are several additional pieces of information that need to be made available to that group. How do we expand that group that Claire's working with? Who can take that on?
I think it just needs to go back to the ICP, because it's very commissioning and issues.
But there were other aspects of it as well. So yes, her commissioning piece, definitely, that would be her. But there were other things that were picked out of her, like the culture of dying, like all of those other aspects, which I don't necessarily, well, I don't think that ICP thinks that's ours. No, so that's the bit that I'm saying, we need to be able to continue to focus on those bits and work out how we can take those bits forward.
What's the enthusiastic?
I was going to say,
I see that. She was like, I'm going to kill you right now.
That's another one.
But it is. I think a lot of it is about understanding and knowledge. I mean, we clearly have some practices who handle these things exceptionally well already, but need additional resources perhaps to do more. And yeah.
And dying is the end of that journey. I mean, I think that's the thing. So actually, it's the lifespan versus health span. And some people have got basically on that road, aren't they, for 10, 20 years. Other people are there for 6 months or 2 days or before mother, even shorter. But I think it's just that awareness. Because I think it's
And I think we need to spend more time with yourself, Leslie. I mean, I would like to have another conversation with yourself and the universities about the researchers, the students, those workplaces, those opportunities of thinking differently, bringing new people into the system and actually working out what differences they might bring to outside of the care system.
Forgive me, I'm going to play the technology card again. There's work being done at the University of Southampton about very much about driving workforce. Handoffs, multiple disciplinary trainings and all that stuff, and it's mature enough because it's being tested in University Hospital Southampton.
Let's get to see
competent people there.
Jim, I think we need to see that work and again circulate it so people get to see it.
We connect it more than likely to their electronic health records,
right?
Which we don't have in Dorset, which we are in the process of putting an outline business case forward to NHS England in June. But that will be a 2-year programme of delivery. So we don't have a single record at the moment. The 3 providers have entirely separate records.
But so I think we need to come back to the next meeting with the work plans really clear, such that we have a work plan for the year, what those elements are and what those focuses are, with people's names against those actions. Partners. Thank you very much for your engagement, for your reports, and for contributing to that. It's really helped. It's been a really interesting discussion together. Thank you.
Fantastic.
I do, yeah.